One, please start. We are now live.
Okay, so good evening, everyone, and good evening, faculty and pharma colleagues. Uh, so it's a great pleasure to welcome you all. It's Oncology Updates in 2024, GI, GU, and breast cancer session. So today we can discuss about GU cancer. Now, I would like to invite to Dr. Asim Samar, sir. He is a senior consultant medical oncology Bhagwan Mahavir Cancer Center Research, Jaipur. So it's over to you, sir.
Thank you, Gitika, and thank you, Team Horizon. I would like to thank Cancer Research and Statistics Foundation and our partner SOMEX. So you might be thinking like every around 6 months we are getting updates and we are doing this update meeting because now in last 6 months or every 6 months in this field GU or GY and breast cancer there are a lot of many things coming forward which can change our practice and we can deliver good practice and updated knowledge to our patients. So we are doing this exercise since last 2 years and it's a very kind of the small meeting, but we have selected the abstract and the topics which can change the practice and we can deliver our uh, best acumen to our patients. So and first speaker was Dr. Siddharth and then Ajay and Dr. Kanika. So as they have not joined and they are in the traveling, so I would
Sir,
request
Ajay sir is joined now.
okay, Dr. Ajay has joined, but we'll start with Acha, he's ready with the presentation, is it? So I will start with the second presentation, that is Dr. Ajay Singh's presentation. And Dr. Ajay Singh is the consultant medical oncologist in Tata Memorial Hospital, Mumbai, and he will be speaking on contact to the phase 3 study of cabozantinib plus atezolizumab versus second novel hormone therapy in patient with metastatic castration-resistant prostate cancer. So, Dr. Ajay Singh, and I would like to thank Dr. Kanika because she agreed for bridging the gap. But anyhow, Dr. Ajay has joined. So, Dr. Ajay, over to you. Kanika, can you please run the slide of Dr. Ajay Singh? Yashika?
Yes, sir, we are running from our side. 1 second.
Yeah. It's a kind of germination of the knowledge because new things are coming in the trial setting and then obviously in the real world setting we
एग्जिट
we,
करके
we
मैं
need
वापस
to test it.
हो गया.
Sir, Ajay sir will be present first, no?
Yeah, Dr. Ajay will be presenting first.
Good evening, sir. Sir, am I audible?
Yeah, Dr. Ajay, yes.
Okay, sir. So actually, my network is little bit weak. I'm also outside, so I'm just using a hotel Wi-Fi. So maybe
No
looks
issue,
like
no issue.
little bit weak only.
No problem.
Are slides visible? Dr. Ajay, you can
Yes,
start.
to me is visible. Can I start now? I'm audible.
Yeah, please.
So, okay, so good evening, everyone, and thanks, Asim sir, for giving this opportunity. So, I will be discussing regarding the role of combination of cabozantinib and atezolizumab in CRPC after progression on first line newer hormonal therapy. Next slide, please. So, coming typically, we know that almost all prostate cancer patients which are advanced metastatic had recurred after basically non-curative, and there are multiple options nowadays in addition to docetaxel, that is newer hormonal therapy like abiraterone, enzalutamide, darolutamide, and all these have now come into the picture even in castrate sensitive prostate cancer whenever needed. However, all these cancers, even this castrate sensitive prostate cancer patient, when we start with treatment, ultimately in some time they progress and become castrate resistance prostate cancer. And for this castrate resistant prostate cancer, the outcome is very dismal. Hardly any patient is surviving 2 years. So median overall survival is hardly around 14-15 months. And even those patients, subgroup of patients who had visceral metastasis, specifically liver or non-pelvic lymph node, they have even more poor prognosis. Next slide, please. So these are few treatment options for metastatic CRPC. Uh, if patient has already received newer hormonal therapy, then generally we prefer to use chemo, either docetaxel or cabozantinib. If patients are not fit for chemotherapy, then we may go on to lutetium therapy or alternative sequential newer hormonal therapy. That is, if abiraterone is given, then maybe enzalutamide. If already enzalutamide given, maybe abiraterone. Or in subgroup of patients who are BRCA positive, we may consider giving PARP inhibitors like olaparib and rucaparib. Next slide, please. So, so rationale for this study that cabozantinib is a multiple receptor tyrosine kinase inhibitor. And in one of the study, that is phase 1b study, Cosmic 021, one of the arm where they have given combination of cabozantinib and PD-L1 inhibitor, that is atezolizumab, they have shown good efficacy of this combination in patient who had progressed and become metastatic CRPC. So this was a phase 1b study where they found there is the evidence of having a good efficacy in this of this combination in metastatic CRPC patients. So this was the rationale and design of phase 3 cabozantinib atezolizumab against sequential newer hormonal therapy in patients who had previously received one of the newer hormonal therapy in metastatic CRPC. Next slide, please. So on the basis of multiple data in metastatic CRPC, where the newer hormonal therapy was used pre-docetaxel, the risk of death was reduced by around 30% with the enzalutamide and 20% with the abiraterone and prednisolone combination. And that has led to the movement of this newer hormonal therapy even in the castrate sensitive patient or non-metastatic CRPC patients. That is, this newer hormonal therapy has now placed not only in advanced CRPC but also in castrate sensitive patients and those who are not having metastatic CRPC on these also. Now these have become one of the first choice agents. So on the basis of results, uh, of the registration trials, abiraterone or enzalutamide in pre-docetaxel metastatic CRPC, in the median OS after disease progression on this new hormonal therapy is hardly around 15 months. So consequently, there was a significant unmet need to develop an effective combination of novel treatments and combination in these metastatic CRPC patients. Next slide, please. So this was the study design. So they included patients who had metastatic CRPC along with the extrapelvic visceral metastasis or nodal metastasis. They should have already received a newer hormonal therapy, and the androgen depression therapy should be continued. No prior systemic therapy was given. Only in docetaxel was allowed those who in the metastatic CSPC setting having a good performance status. These patients were randomized in 1:1 fashion to combination of cabozantinib or atezolizumab against standard arm, that is sequential either abiraterone or enzalutamide if, depending upon the initial newer hormonal therapy given in the first line. And this treatment will continue till this clinical benefit or intolerance toxicity. The stratification factors was having a liver involvement, prior docetaxel used in CSPC, disease state where when the newer hormonal therapy was started, whether it's metastatic CRPC or non-metastatic CRPT or metastatic castrate-sensitive prostate cancer. The primary endpoint was radiological PFS in initial 400 patients and OS in all intention to treat population, with a secondary endpoint of overall response rate. Additional endpoints included safety, pharmacokinetic, and biomarkers, and there were other factors were assessed like bone scans, patient-reported outcome at recommended intervals, and safety and survival at every 3 weeks and every 8 weeks respectively. Next slide, please. So these are the baseline characteristics. So you can see that there was around 23 and 24% population had liver metastasis. Means these are the poor population. Almost 1/4 of the population had a liver metastasis in this trial, and also you can see that around 40% population in each arm had visceral metastasis, and around 75% population had extra pelvic lymph node involvement. And prior docetaxel was given in one-fourth of the population in both the arm, that is around 23%, in the metastatic CSPC setting. And almost majority of the patient had metastatic CRPC, that is around 75. Three-fourth of the population had metastatic CRPC when the first neurohormonal therapy was given. And around the first line neurohormonal therapy, around the duration of that neurohormonal therapy in the first line was around 12 months. So coming to the outcome, next slide, please. So we can see that the radiological PFS was significantly improved. Next slide. Significantly improved around 6.3 months in the experimental arm, that is cabozantinib and atezolizumab, and around 4.2% in the 4.2 months in the subsequent neurohormonal therapy, and with a hazard ratio of 0.65, not causing unity with a very significant p value. Next point, please. Next slide, please. And again, doing the subgroup analysis, all the subgroup, that is those who are having a poor subgroup, that is liver metastasis, who has received already prior docetaxel, you can see that hazard ratio was 0.43, 0.57, and even those who had bone metastasis, hazard ratio was 0.67, and there was none of this subgroup was crossing the hazard ratio of unity. So almost all subgroup population had shown significant benefit compared to the second newer generation hormonal therapy, compared to the cabozantinib and atezolizumab. Next slide, please. And for OS, it is because this data analysis was did around 1 year, around 12 months in the experimental arm and 14 months in the standard of arm. So the OS data is immature, but still there is a trend toward improvement in overall survival, and it was around 16.7 months in the cabozantinib and atezolizumab, and 14.6 months with a hazard ratio of 0.79, crossing the unity of 1.07. So still we need to wait for the overall survival. Only 49% event has happened till the reporting of this. So we need to wait for the mature OS. Next slide, please. So this is the another this is the secondary endpoint, that is overall response rate. So overall response rate was higher, around 13% in the experimental arm and 4% in the chemotherapy, newer standard of arm, that is newer hormonal therapy in the subsequent line. Next slide, please. So the median duration of response was higher in the cabozantinib was around 9.7 months, and other than this, the median time to systemic chemotherapy was prolonged, uh, with a hazard ratio of 0.56 in the experimental arm, but other things are still immature, like uh, that is symptomatic skeletal events and other events. The almost it was non-inferior to the second generation newer hormonal therapy, but the duration of response and the time of to second line chemotherapy was significantly prolonged in the cabozantinib and atezolizumab arm. Next slide, please. And coming to the safety part, so again, there was no significant means the alternative red flag signal in the combination of cabozantinib and atezolizumab. It was almost expected the side effects which are known. The most common one, hypertension, and then diarrhea and diarrhea and weakness, which was more common in the cabozantinib and atezolizumab, which is already known side effects, and these were manageable. And grade 5 side effects were around 8% in the cabozantinib atezolizumab and 12% in the second newer hormonal therapy arm. So again, coming to the safety part, it was looks like no known side effects, and there was no any red flag signal. And those grade 3 and 4 side effects were manageable in our day-to-day OPD practice. Next slide, please. So coming to the conclusion, so cabozantinib and atezolizumab significantly improved the radiological PFS against the second hormonal therapy in patients who had progressed on prior newer hormonal therapy in the first line and have metastatic CRPC with poor features like extrapelvic nodal disease or visceral disease. So in this unmet, they have shown significant improvement in radiological PFS. These radiographic PFS benefits were particularly notable in patients who had liver mets and those who had received prior docetaxel in the metastatic CSPC setting. OS data is mature, but there was a trend toward improvement with this experimental arm, including high-risk population. Toxicity is reported with each treatment arm were manageable. So this Contact 02 trial is the only phase 3 study of immune checkpoint inhibitor-based regimen to show significant and clinically meaningful improvement in radiological PFS in prostate cancer with visceral metastasis. Follow-up of overall survival is ongoing. So these data support the combination of cabozantinib and atezolizumab as a potential new treatment option for patients with metastatic CRPC who have progressed with prior novel hormonal therapy in the first line. So with this, I like to end my talk, and again, thank you, Asim sir and team, for giving this opportunity.
Thank you, Dr. Ajay. It was a nice talk, and actually, many a times we find like stuck with the patient, Dr. Ajay, where we don't have any good option to offer to the patient who have metastatic CRPC, and we have exhausted 2 or 3 lines. So now I guess this immunotherapy plus cabozantinib combination might give some relief to that patient who can afford the therapy, right?
Yes, sir, definitely. Now the the PAP scheme also for all immunotherapy has become very lenient. So
Yes, yes, yes.
yearly cost is hardly around 7,000, 7 lakh or 8 lakh. So maybe means almost middle class population of Indian, they are having around 10 lakh, 15 lakh insurance. So now
Yes, yes.
almost access to this immunotherapy will be more and more. And now with this data, this may be one of the PAP, the improvement means approval will be easy for this with this data.
Exactly. And what sometimes happens is if you give 1 or 2 years to the patient more, there may be some relief in terms of the finances, because now cost has come down with many treatments, and you can see like some new emerging treatment might come in that period when the patient buy for some time. So it's good to have discussion with the patient, like you have an option of immunotherapy also, and cabozantinib is VEGF inhibitor, so there might some role in delay the progression. So it's I guess in real world setting we will further experience the thing, but still it opens some gates for the relapse and refractory setting. So thank you very much, Dr. Ajay, and I would like to invite our next speaker. So third speaker is Dr. Kanika. Let me check. So
Yes, sir. It's our next speaker is Dr. Kanika.
yeah. So just let me open the things. So, Madam Dr. Kanika is Associate Consultant in Medical Oncology Department, Max Hospital, Mohali. And Dr. Kanika will be speaking on BRCA-way, a randomized phase 2 trial of Abritron, olaparib, or Abritron plus olaparib in patient with metastatic castration-resistant prostate cancer bearing homologous recombination repair mutation, HRR mutation positivity. So this is again a new era in the various cancer. We have seen in ovarian cancer also, now in prostate cancer. So you see like various discoveries are going to happen in second and third line. So BRCA-ness or molecular signature about this might help us to treat the patient. So over to you, Dr. Kanika. Uh, yeah,
Good
you
evening,
can
sir.
start now.
And thank you for giving me this opportunity. And as you rightly said that every few months there are new agents and new
Yeah.
trials that are coming up. So today I'll be discussing about this BRCA-away trial. Is my slides visible?
Yeah.
So yeah. So
And
I'll be
sometimes,
discussing.
Kanika, it's very difficult to make a pace with the new discoveries or new treatments, and until unless you have a support of various residents and you have a departmental curriculum for the teaching and all that. Otherwise, it's very difficult to keep the following the various trials, various journals, and path-breaking discoveries.
True, sir.
Until unless you are going every 1 or 2 months in a large conference, you might be in touch. Otherwise, it's very difficult. Yeah, over to you.
Okay. So I'll be discussing about the BRCA-away trial. It's a phase 2 trial of Abiraterone, olaparib, given singly or in combination in HRR mutant metastatic CRPC. So as we know that olaparib monotherapy, it is approved for adult patients who have a deleterious or a suspected deleterious germline or somatic HRR gene mutation in the patients who are metastatic castrate-resistant prostate cancer, in patients who have progressed following prior treatment with either enzalutamide or abiraterone. So, when seen in the preclinical model, so they have seen that the PARP inhibition plus androgen receptor inhibition, they have a synergistic property, and upfront combined inhibition of both pathways, they have a additive effect when given in the sequential therapy. So they interact with the androgen signaling, and therefore this trial was conducted, which evaluated the patients who were given sequentially, that is abiraterone prednisolone versus olaparib versus the combination in the first line treatment in biomarker pre-selected patients, so who have a germline or somatic mutation in BRCA1, BRCA2 or ATM gene. So they were taken for this study. So they have reported the progression-free survival, the measurable disease response rates, the PSA response rates, and the safety profile of the combination therapy as compared to the single therapy. So since this trial was initiated, FDA, they have approved olaparib in combination with the abiraterone and prednisolone for the treatment of adults patients with deleterious. So by that time, the PROPEL trial data was there that have shown that the combination can be used in the patients who have a BRCA mutation. So when we talk about the study design of this protocol, so it's a open label randomized multicentric phase 2 trial in the patients who have a metastatic CRPC along with a germline or somatic mutations. So they were detected by NGS. Patients should not have received prior exposure to either a PARP inhibitor or an androgen receptor inhibitor or chemotherapy for the setting. There should be a washout for anti-androgen. That is, a few weeks gap has to be given before the previous therapy was stopped, or any radiation or other investigational agent. So they have taken around 61 patients, and they have equally divided in the arm 1, that is the abiraterone alone arm, followed by olaparib or the combination arm. And they have assessed the patient until there is a radiographic progression or unacceptable toxicity, and the crossover between arm 1 and 2, they were allowed upon progression. So the patients who progressed on abiraterone, they were taken for olaparib and vice versa. So the primary endpoint was progression-free survival, and the key secondary endpoints were the overall response rate, the PSA response rate, and the safety profile of the combination. So when we look at the baseline characteristics of the 3 arms, so they are comparable with the median age of around 65 to 66 years. That is the usual age we see in the practice for the CRPC patients. All of them, they have a performance status of either a 0 and 1, with a median PSA ranging between 3.7 to 133. The most common site, as we also see in the clinical practice, is the bone, followed by the pelvic and the abdominal lymphadenopathies, and visceral metastasis, they are seen in around 11 to 20% of the patients. So when we talk about the measurable disease, so most of the patients, they have measurable disease. And when we talk about, it's equally distributed between the germline mutated patients and the somatic mutated patients. And most of the patients, they have a BRCA2 mutations. So when we talk about the efficacy outcomes in all the 3 arms, as we can see, the median PFS, there was a significant difference as we move from arm 1 to arm 3. So it was 8.4 months in the abiraterone arm, which improved to 14 months in the olaparib alone arm. But when we use the combination, it is greater than the combined PFS of both the arms. So that is the 39 months. That is significantly prolonged as compared to each of the arms. When we talk about the overall response rate also, again, it was seen in 22% versus 14 versus 33%. And the PSA response rate around 95% of the patients. So almost all of the patients, they have a PSA response rate. In practice, we don't really give that much importance, but yeah, even if we are not saying it, that the patient keep on, getting the PSA done for their satisfaction, that how much the disease is responding. So it is good that even this regimen, they have a PSA response rate. So patient at least have some confidence in the treatment that they are responding. And the undetectable PSA response rate was seen in 33% of the patients. So patients who were receiving combination therapy, they have a significantly greater progression-free survival when compared to the either arm alone. So as I told earlier also that their crossover were allowed between the two arms. So when we talk about the median PFS from crossover, so in the arm 1, when the patients have received, when the patients have received Evratron in the first line and then they were crossover to olaparib, then also the median PFS was 8.3 months. So even if we combine the both, that was 8.4 versus 8.3, then also it is hardly less than 20 months also. Again, vice versa, when we, there is a crossover from olaparib to Evratron also. So as we have seen in the lung also that even with the PFS 1 and 2, the best regimen used in the first line setting, they have a better overall PFS as compared to the sequential therapy. Again, the overall response rate also, even with crossover, it is 38% versus 25%. When we talk about the adverse effect, which is actually the main point with that, whether the quality of life is not hampered or whether the adverse effect should not have increased with the combination therapy. And when you look at these figures, it's not that different from the single arm. So if we just compare olaparib with Evratron plus olaparib only, so grade 1 to 3 toxicity is relatively similar. So there is no as such additive side effects when we talk about the combination therapy. Even the anemia, the percentage is significant. The slightly rise in the anorexia, but otherwise it is a well tolerated. The fatigue is slightly higher, but otherwise overall the tolerance is there. So grade 3 increase in ALT were observed at 11% and 5.3% with AST in the Evratron arm. And there was no related grade 4 or grade 5 adverse effects seen with this. When we talk about the adverse event in more than 15% of the patient who crossed over between, so even during crossover, you see that there is increased fatigue was there when they have. So these are the general side effects that are actually seen in the olaparib arm whenever we use in the other setting also. So there were as such no grade 3 adverse effects in the crossover to olaparib arm, and it was a well-tolerated regimen. So concluding this treatment with Ebiratron plus olaparib, it resulted in a longer PFS and a higher overall response rate when we see this sequential therapy of both the agents in the patients who have a BRCA1/2 or ATM alteration. And the median PFS was 39 months, which is significantly prolonged versus 8.4 and the 14 months with the single agents. And again, when we are using a sequential treatment also, with the crossover arms also, it resulted in a shorter median PFS from randomization. And we also know that the quality of life and the PS of the patient also deteriorate with each progressive therapy. So there was no new safety signals that were observed with the combination arm. And they support that the upfront use of PARP inhibitor and a AR inhibitor combination can be used as a first-line therapy for the metastatic CRPC patients who have a germline or somatic mutations. Thank you so much.
Thank you, Dr. Kanika. Such a nice presentation. So you see, like almost 8.4 months to 39 months. Unbelievable, they have increased the PFS. And you rightly said PFS 1 and 2 can't make if you start the right treatment at right place.
True.
So it is almost you can see even if PFS 1 and 2 you add, then it is also 2.5 times, I guess.
Yeah, less than 20 months, and still it's double than
Double. So it's very nice.
It's
And nowadays, we rampantly we are doing the BRCA and BRCA2 testing or HRD testing. So if we find a suitable patient, our aim is to start the treatment. And you see, very soon generic olaparib might available. So further the scene will change. Yeah. Thank you very much. Thank you, madam. So next, I would like to invite our dear friend Dr. Anuj, and he is the consultant assistant professor in TMH Varanasi. And Dr. Anuj Gupta will be speaking on role of PARP inhibitor in prostate cancer. Anu is traveling, I guess he is in the car.
Thank you, sir. Thank you for getting me in the conference. And actually, I am rightly guessed. I'm traveling outside. So I'll be talking about the role of PARP inhibitor in prostate cancer. So it is general discussion about the mechanism and the available data in the PARP inhibitor in metastatic setting. So we know that PARP inhibitor has established its role in ovarian and breast cancer, and now we have increasingly new data for the PARP inhibitor when there is a specific DNA repair pathway defects in certain cancers, and in prostate cancer also. PARP inhibitor has shown promising results in both preclinical and many of the clinical studies. So understanding the role of PARP inhibitor in prostate cancer becomes crucial for developing effective treatment strategies. Next slide, please. So DNA repair mechanism has been already discussed at multiple platforms, but just to give a brief overlay, DNA damage techniques. DNA damage may be in the form of base mismatch, single strand DNA breaks, DNA adduct formation, or double stranded DNA breaks. And there are specific mechanisms for the repair of these DNA so that the damage can either be eliminated or are repaired. So PARP are one of these essential component of this DNA repair mechanism when there is single stranded DNA break, and by this the DNA single strand repair is done. But when there is BRCA mutation, then there is a role of PARP inhibitor in which we or there is when there is homologous repair recombination deficiency, then there is a role of PARP inhibitor, and by giving PARP inhibitor, we convert this single strand DNA breaks into double stranded DNA breaks, and ultimately these cells undergo apoptosis and the cancer cells are killed. Next slide, please. Next slide. So now we have two established molecules for its in May 2020 for the metastatic CRPC with deleterious or suspected deleterious HRR gene mutations, whether it is germline or somatic, and the progression following prior treatment with enzalutamide or abiraterone, it has been approved based on the PROFIND phase 3 efficacy data showing significant improvement in the radiological PFS and overall survival. Drucaparib also was approved. Accelerated approval was given in May 2020 based on the phase 2 Titan 2 data, which was a data of around 115 patients in the patients who were previously treated with AR-directed therapy and taxane-based chemotherapy. Other Titan 3 trial for further establishing the data is still under evaluation. Next slide, please. So several clinical trials are phase 2 and phase 3 trials are available for us to establish its efficacy in advanced prostate cancer. The PROFIND trial demonstrated that olaparib, a PARP inhibitor, improves progression-free survival in metastatic castration-resistant prostate cancer patient with DNA repair gene alteration. Also, these findings highlighted that potential of PARP inhibitor as a target therapy for prostate cancer patients with specific gene alteration. Next slide. This is a slide which shows some landmark trials of both olaparib and niraparib, and in BRCA trial, which was a phase 2 trial, has already been discussed by the previous speaker, and the results have been already discussed. The other phase 3 trial is Propel trial and magnitude trial. In Propel 3, in the unselected patients, irrespective of HRR, retrospective HRR testing was done in this patient. Olaparib was compared with androgen abiraterone plus prednisolone versus placebo, along with the abiraterone and placebo. And in this, we can see the difference in the radiological PFS. It was increased from 16.6 months to 24.8 months. For niraparib in the magnitude trial, which was again a phase 3 trial, in which prospective HRR mutation stratification was done. Niraparib was given in 200 dose with the abiraterone steroid plus prednisolone versus placebo in the comparator arm, along with abiraterone acetate and prednisolone. And again, we can see the radiological PFS was 10.9 months versus 16.6 months in favor of the niraparib arm. Next slide, please. So in this two trial, we can see the graph for magnitude, all HRR positive patients, and Propel in all patients irrespective of the HRR status. And we can see the radiological response, radiological PFS. And as discussed already in the previous slide, we can see the better hazard ratio and better response rate for the niraparib plus the abiraterone acetate in the magnitude arm, and in Propel we can see the better results of the olaparib compared to the other arm. Next slide, please. So combination therapies with PARP inhibitor is being investigated in the prostate cancer, and combining PARP inhibitor with other agents such as hormonal therapies or immune checkpoint inhibitors are being explored. There are preclinical studies that have shown synergistic effects when combining PARP inhibitor with androgen receptor targeted therapies in prostate cancer models, and clinical trials are underway for evaluating efficacies of PARP inhibitor with immunotherapies as well. Next slide, please. So here we can see all the trials have been clubbed together. What are the trials, ongoing trials, and the trials which are having which have been completed. So for the combination of androgen receptor therapies with all the molecules, that is olaparib, talazoparib, rucaparib, and niraparib, we have phase 3 trials, and quite a few trials have met their primary endpoint. Propel and magnitude has already been discussed. For rucaparib, it was Casper trial, and for talazoparib, it is TALAPRO-2 trial. Similarly, with immunotherapy combination, Keynote trial, Javelin trial, and Checkmate trial of specific their specific immunotherapies along with combination of PARP inhibitor are being conducted. Other co-targets are also being explored, and they are done in combination with the various PARP inhibitors, and which results of them are still not available to us. Next slide, please. So what are the FDA approved drugs or PARP inhibitor combination available to us? In May 2023, olaparib with abiraterone and prednisolone was approved based on Propel trial. Based on TALAPRO trial in June 2023, we have recommendation for talazoparib along with enzalutamide, and in August 2023, based on magnitude trial results, we have approval for niraparib and abiraterone with prednisolone in the metastatic CRPC setting. Next slide, please. So what is other thing we need to take in consideration is the resistance, how they may develop resistance to the PARP inhibitor. It can be by the mechanism of by the restoration of DNA repair pathway or alteration in the drug targets can be the mechanism. And understanding these mechanisms and the pathway or other molecules to bypass this resistance mechanism is a major challenge in the treatment of prostate cancer. Next slide. For predicting the response to PARP inhibitor, biomarker testing is important, and these biomarkers can predict response to PARP inhibitor. In prostate cancer, biomarkers such as HRR or HRD, HRD score or HRR, and mutational gene signature may be helpful to predict response to PARP inhibitor, and integrating biomarker testing into clinical practice can improve treatment outcome and guide therapeutic decisions in prostate cancer. Next slide, please. Adverse effects have already been highlighted. These are same as was discussed in the BRCA away pathway, and majority of the patients can have fatigue, nausea, and anemia. Although managing these side effects through supportive care is important and usually well managed, and close monitoring and dose modification can help mitigate adverse event and improve tolerability to PARP inhibitor in prostate cancer patients. Next slide, please. Talking about future direction for this PARP inhibitor, then ongoing research is focused on developing novel PARP inhibitors with improved efficacy and safety profile. Combination therapies involving PARP inhibitor and other targeted agents are being explored to enhance treatment outcomes and available options, and personalized medicinal approach that incorporates biomarker testing will continue to play a key role in optimizing the use of PARP inhibitor in prostate cancer. Next slide. To conclude, PARP inhibitor has emerged as promising therapeutic strategy in prostate cancer, particularly in patients with specific genetic alterations. Understanding the mechanism of action, biomarker for response prediction, and strategies to overcome resistance are key areas of research in this field. And continued advancement in PARP inhibitor holds great potential for improving outcome and quality of life for prostate cancer patients. So with this, I'll end my presentation. Thank you.
Thank you, Dr. Anuj. Nice talk, Anuj. And you are coming from the hospital? You are in the way to home?
No, sir, actually,
You're going out?
have come for a dinner with my family because it's
So
my
sorry.
birthday.
Seniors are not leaving you, huh?
Yes, sir.
Okay, but it was nice presentation, and obviously, this is an arena where we can work together because nowadays PARP inhibitor plus older therapies, Abetron and enzalutamide are coming. So we can pass on this benefit to our patient. And nowadays, if we see like patient is HRD positive or BRCA positive in ovarian cancer or prostate cancer, we feel very, you can say enlightened actually, to start the therapies because therapies are now getting cheaper and cheaper. So thank you very much. And I guess prostate cancer patient might be the survivor actually in forthcoming years because of this thing, right? So thank you, Anuj. Thank you once again for
Thank-
joining us. And now
Thank you,
I
sir.
would like to invite Dr. Siddharth Turkar. Is my good friend, and he is the director of Radiant Super Specialty and Cancer Hospital, Raipur. And Dr. Siddharth will be speaking on a phase 3 trial to compare treatment with lutetium PSMA therapy plus standard of care versus standard of care alone in the patient with metastatic hormone sensitive prostate cancer. So it is basically in the first line setting. Thank you, Dr. Siddharth, and over to you, Dr. Siddharth.
Thank you, sir, for the kind introduction. And so this study was presented in ESCO 2023 in an abstract form. It is about a phase 3 trial to compare the treatment with lutetium PSMA treatment with standard of care or in comparison to standard of care alone in patients with metastatic hormone sensitive prostate cancer. Next slide. So coming to the background, so PSMA is a promising theranostic target for prostate cancer owing to its expression in around 90% of all prostate cancer and its limited expression in non-prostate cancer tissue. So lutetium PSMA 617 is a high affinity PSMA targeted radionuclide therapy that delivers the beta particle radiation to PSMA expressing cells and their surrounding environment.
Okay.
In the phase 3 vision study, the lutetium PSMA protocol permitted standard of care significantly improved radiographic progression-free survival and overall survival in patients with PSMA positive metastatic castrate-resistant prostate cancer. However, ADT and androgen receptor pathway inhibitors may alter PSMA expression and radiosensitivity. So when it is being given afterwards this treatment, then the efficacy of this treatment can get affected. So to actually explore the possibility, if we can sequence this treatment early rather than giving it after the ADT and androgen receptor pathway, whether it is going to help this thing. So this study is about the same. Next slide. So the overview of the study is that it is an international prospective open label phase 3 trial that will enroll around 1,126 patients, and the eligible patient are treatment naive or minimally treated candidates for hormone therapy with PSMA positive disease. Patients were excluded if they have rapidly progressing tumor that require chemotherapy. It will be a 1:1 randomization to receive either lutetium PSMA plus standard of care or standard of care alone. Next slide. So this is the study design schema. So I have already told you the eligible population. So 1:1 randomization is between standard of care plus PSMA versus standard of care. The post-treatment, the primary endpoint of the study is progression-free survival. And next slide. The planned sample size provides 95% power to detect a hazard ratio of 0.7 for radiographic progression-free survival after 418 events with an overall one-sided significance level of 0.025. Next slide. Wait. The previous slide. The stratification factors are tumor volume, whether it is high or low, age more than 70, less than 70, and previous planned prostatectomy or radiation treatment of the primary prostate cancer. Next slide. The secondary endpoints are overall survival, proportion of patient with PSMA decline of more than 90% from baseline, time to development of metastatic castrate-resistant prostate cancer, composite progression-free survival, safety, tolerability, and health-related quality of life. Imaging and biospecimen collection is embedded for correlative analysis later on. Next slide. So currently this study is ongoing, and the shaded areas are recruiting the study patients. The first participant was enrolled in June 9, 2021, and 176 centers are right now recruiting the patient. So this study is estimated to complete by February 2026, and we are actually awaiting the study results. Thank you. So right now we don't have basically the results of this study, but this is the basic motto of the study, whether if we can sequence the treatment early for this patient.
Thank you. Thank you, Dr. Siddharth. Just a minute. Okay. Thank you, Dr. Siddharth. I guess you are traveling in a very, distant way, huh? It's completely dark and all that, huh? Who is driving, you or driver?
The driver is there, sir. Actually, I have gone for basically a CME at some other place for
my
a मतलब local physicians के साथ एक उसमें meeting में गया था, इसलिए थोड़ा late हो गया.
But you are the director, huh? Actually.
Yeah.
So you need to do this, huh? Okay, it was a nice presentation, right? And Siddharth, I guess you have finished CMA and all that. So, okay, we'll move on for the next topic of presentation. So I would like to invite our next speaker, Dr. Abhishek Sharma. So he'll be speaking on, it is a session sponsored by the AstraZeneca, and it is, the topic is agonist versus LHRH antagonist. Dr. Abhishek Sharma is
Yes,
a
sir.
consultant medical oncologist and hematologist at Goyal Hospital, Jodhpur. And Dr. Abhishek,
Yes, sir.
yeah,
Sir, please allow to me share.
yeah. Abhishek, how is the life in Jodhpur?
Yes, sir. It's good actually.
Relaxing, right?
It's my home, so that's why it's good, sir.
Yeah, I done my MD from there, so
Yes, sir.
I
Yes, sir.
often miss that place actually.
Yes, sir.
Seems to be very hot in the concept, but it is very nice place.
Yes, sir. Yes, sir. So let's start. We are discussing the controversy between LHRH agonist versus antagonist. As we all know, the prostate cancer is the second highest incidence in the worldwide and the fifth leading cause of death in the males in the worldwide. And in the Indian scenario, you can see in this bar charts that the prostate is the incidence is around fifth number and or mortality almost high in around fourth to fifth in among other cancers. So definitely prostate is a cancer that a good incidence of number and related to mortality is also high with the prostates. So let us discuss about the paradigm the prostate cancer. This is definitely starting the patient with the high risk localized disease, and we have a treatment option of wakeful watching, some radical prostatectomy, radiotherapy, and hormone therapy, neoadjuvant as well as adjuvant also. And in the locally advanced in the treatment part is the neoadjuvant hormone therapy. We have a radical prostatectomy. We have an option of a hormone therapy alternate to the surgical castration. And for HSPC, as we all know, we have an option of hormone, enzalutamide, other target agents, abiraterone and all. And the same with the castration CRPC, we have almost similar kind of therapy in the prostate. So you can say the hormonal therapy on the for the in the form of any agonist or antagonist is the same in the all setting. You can use from high risk to CRPC setting. So I discuss about the what is the pathway for discuss about agonist. Agonist basically is the synthetic protein that is structurally similar to the LHRH and bind to the receptor in the pituitary gland, and after that gland produced to stop LH, and so there's no testicular stimulations and there is a stopping of the formation of the androgens, so definitely lowering the testosterone level. When we talk about the antagonist directly bound to the LHRH receptor, and so the no production of the LH, and definitely there is no production of the androgens. So pathways may different, but the finally action to stop the formation of the androgens. So I am discussing what is the castration level between antagonist and agonist. Definitely, there is an antagonist have a receive that level castrate level up to 96 hours, but the agonist is around 3 to 4 weeks. Flare with the antagonist is no. Agonist, yes, definitely is the problem. PSA failure is high in the antagonist. Agonist 14 versus the antagonist is 8%. But the main complication with the antagonist is the local injection reactions, around 40% cases, almost similar in the all evidences versus 1% with the agonist. Cardiovascular complication with the same. Administration is quite frequent with the antagonist is monthly, but the agonist is only 3 monthly. So definitely all LHRS agonist equally. LHRS antagonist important in the patient who need rapid reduction of the testosterone, with the patient with severe symptom of the obstruction, spinal cord, some severe GI obstructions and paraplegia, severe bony pain. Definitely we need to need antagonist for the patient to prevent the flare. So now discussing of some pharmacokinetics, you can see for the discussing gozerline monthly, 3 monthly, and degarelix monthly dose. The Cmax is 2.3 versus degarelix is 66. Tmax is almost very high with the degarelix. The area under curve is also high with the degarelix, and the plasma protein binding also high with the degarelix. So on a pharmacokinetic basis, degarelix is rapid with the all distributions and the action also. So no dose, but the concern is that what is the patient about the hepatic derangement? That there is no dose adjustment required for mild to moderate hepatic impairment with the gozerline, like unlike degarelix. So now discuss the role of the LHRH agonist gozerline in the prostate cancer settings. We have a localized prostate cancer, locally advanced, and metastatic disease. So for a localized cancer, we have a data with the AORTC and DART. AORTC use adjuvant gozerline and DART use adjuvant as well as neoadjuvant gozerline, and the final crux of the disease of the this studies is 40% improvement in the 10-year overall survival when compared to the RT alone. The hazard ratio is quite significant with a significant p-value less than 0.0004. So this is a study. They divide patient newly diagnosed prostate cancer in 1:1 randomization, radiotherapy plus 3-year gozerline monthly with the radiotherapy alone. Primary endpoint by the OS and secondary endpoint by the disease-free survival and cause-specific mortality. The median follow-up of this study is around 9.1 months. And you can see the 10-year DFS with the gozerline is 47 versus 22% with a significant p-value and the significant hazard ratio. But while the prostate cancer mortality, that is also quite improved with the gozerline and radiotherapy, it's only 10% compared to the 30% with the radiotherapy arm. And so finally, discuss about the survival. Yes, 10-year survival with the Gozalin radiotherapy arm around 58% versus 39% with the radiotherapy arm. So definitely a quite 40% reduction in the risk of death with the adjuvant Gozalin. So we have a good evidence of LH agonist in the high risk setting. Now discuss about the DART. DART has to discuss neoadjuvant Gozalin followed by radiotherapy versus neoadjuvant radiotherapy, then adjuvant Gozerlin. The primary endpoint DFS and secondary endpoint same as a OS and DFS, with the median follow-up of duration is around 62 to 64 months. And the biochemical DFS, when we discuss about in this DART trial, they have a 5-year DFS around 90% in the Gozerlin arm compared to the 81% in the short-term Gozerlin. So definitely they have a good data with the long-term Gozerlin. So yes, we have a evidence with that, and the overall survival also is good with the Gozalin arm, that is long term versus compared to the short term. The p value is significant. So definitely the patient, any patient with the high risk disease, we have a data. Gozalin agonist is a good survival benefit, and compared to the short term versus long term, there are definitely a survival as well as DFS benefit with the Gozalin therapy. Now discuss about the locally advanced prostate cancer. We have a data with the RTOG, PROG, and GAT-UG AFU16. The crux of disease is 46% reduction in the risk of progression over 10 years when compared to the RT alone in this studies. The good hazard ratio is 0.5 and the good significant p-value. We discuss about some part of the RTOG. The patient who has a locally advanced disease, T2 to T4, with or without pelvic lymph node, they plan for neoadjuvant Gozerlin plus glutamide, followed by the radiotherapy plus glutamide compared to the radiotherapy alone. And the primary endpoint was the loco-regional control, and loco-regional control defined as a progression of palpable tumor at any time, persistent of palpable tumor beyond the second year, and positive biopsy 2 years or more after study entry. And the secondary endpoint of this study was DFS, OS also, and this study conduct median follow-up of the 6.7 year. A 10-year survival update was performed at the median follow-up around 12 year and 30 year, all living patients, those who are on Gozerlin, glutamide, and RT arm respectively. And same as a TOG also compare with the 3-arm, 6-month arm with the neoadjuvant and glutamide, Gozerlin plus glutamide, 3-month Gozerlin glutamide, and 1 arm is the only radiotherapy arm, and the same endpoint is the local control and prostate cancer death. And same the secondary endpoint, biochemical folio, distance-free survival, disease-free survival. The median follow-up is also quite good, is around 6 years, and the median follow-up is around 10 years. Those who have survived 10 years. So this is the 10-year follow-up of the RTOG in the locally advanced disease. You can clearly see the 10-year 23 versus 35% patient had died of prostate cancer in the Gozerlin arm versus the RT arm alone, and the p-value is 0.04. So definitely those who are received Gozerlin with the RT, definitely mortality, disease-specific mortality is quite low compared to the RT alone, and same in the TROG, prostate cancer specific mortality is low. In the 0-month arm, you can see is 22% versus 18% versus 11-month is 11.4%. It's a those who have received 6-month arm. So definitely there is a mortality, there is a low mortality with the LHRH agonist Gozerlin arm. And so when we discuss about the survival, yes, definitely a survival benefit with the 42 versus the 33% with the significant p-value in the both the trial, RTOG as well as TROG. And there is benefit also 3-month and 6-month arm also. When discuss about the GAT-UGFP, they discuss the patient, those who have received, those who underwent the radical prostatectomy and rising PSA after 6 months of therapy. Any PT2, PT3 or PN0 or PNX patient quietly randomized in 6-month Gozerlin plus radiotherapy versus radiotherapy alone. And the primary endpoints of the disease are the same as a PFS. Secondary endpoint is OS, metastasis-free survival, toxicities, time to neither randomization to the neither PSA, quality of life, and functional independence for those who are patient or older one. And the primary analysis of the median duration follow-up is around 63 months was done, and long-term analysis was done on the 110 of the month. And you can see the those who received 10-year PFS is 64% patient with the Gozerlin radiotherapy versus radiotherapy alone arm. So there is a 46% reduction in the risk of progression or death with the adjuvant Gozerlin post-radical prostatectomy. So definitely Gozerlin have a good evidence in the all setting in the neoadjuvant, adjuvant as well as the adjuvant setting post-radical prostatectomy. So we analysis the subgroup analysis for the same studies, and we found the all subgroup as benefit with the gozerlin and plus radiotherapy. Those who are more than 65 year, less than 65 year, those who are low risk or high growth person, any type of IMRT, any type of any amount of PSA at baseline, and PSA doubling time less than 6 months or 4 months, and PSA pre-surgery PSA more than 10 or less than 10. So definitely all group benefit with the gozerlin and radiotherapy arm. And next, talk about the metastatic prostate cancer. So this is as effective as surgical castration in clinical outcomes. As we all know, there is no clinical differences we seen in the groups where some patient undergone the surgical orchiectomy versus the medical orchiectomy. Gozerlin versus orchiectomy is compared with the Kazeri and Vozilens. They compared with the this both is the phase third randomized trial. They compare orchiectomy with the Gozerlin 3.6 monthly, and the same with the monthly arm. This is the both are the phase third open multi-center trial, and there's considered the patient those who are metastatic prostate cancer, and the median follow-up is also good, and the median duration of survival was approximately in 2 year in the Kazari studies, and Vozling is around 4 year. So definitely you can see the overall response rate with quite similar with the surgical versus medical. Median time to response is also similar in the both arm. Median response to duration, median response is also similar in the both group. Median time to failure is also similar in the Vozling, but there is some difference in the Kazari arm, 26 versus 40 months, but there is some flaws in that. So median survival is almost similar with 99 versus you can see in this graph. So definitely there is no any inferior data that is suggestive of medical castration is definitely is non-inferior to the surgical castration. Those are the randomized trial they have answer. So definitely I summarize my that that agonist that have it 40% improvement in the 10-year OS in the localized prostate cancer, 46% reduction in the risk of progression at 10 year in the locally advanced cancer. At in metastatic prostate cancer, they are as effective as surgical castration in clinical outcomes also. So now we have a guidelines. What is the so definitely all we know about the guidelines. High risk definitely we treat with the ADT plus radiotherapy. All are similar. Some are favoring neoadjuvant, some are favoring adjuvant, but definitely answer is surgery or ADT plus radiation therapy. Locally advanced disease, those who have a regional node and something. So definitely they have all same answer. ADT plus, some have a abiraterone also, and RT plus ADT, neoadjuvant ADT plus RT or surgery. This is the answer only. For the metastatic disease, definitely we have a quite a discussion about that. So we have a agonist or antagonist, both are approved in the castration resistance and castration sensitive also prostate cancer. So definitely we all know. So castration level of student should be maintained by continuing LHRS agonist or antagonist while addition therapies are applied. So as we all know, we are continuing with the medical castration whenever any therapy patient on continuing. So we have an option of gozerlin, lupolide, triptorelin, buzerlin, and degarelix. So that gozerlin to the buzerlin is the agonist, and antagonist we have is also degarelix, and right now we have some oral antagonist also regularix. So the approval that a good evidence for this agonists, you can say gozerlin is highly approved for the high risk, local advanced, and metastatic. Lupolide has good evidence also. Triptorelin has same evidence, but a high risk localized disease, buzerlin and degarelix have not any good evidence. So this is not actually recommended in this setting. And locally advanced and metastatic all are recommended as all are clinical decision on the basis of patient fitness and patient other comorbidities. So they can plan for any one of the agent on the basis of their fitness. So gozerlin is available as a 3.6 milligram and 10.8 milligram implant in a default form. You can plan with the subcutaneous or intramuscular also. So 3.6 is a monthly therapy and 8.10 is a this is a 3 monthly therapy, single step delivery system, minimal administration time, and additional advantage is that this is the 3 month therapy is basically patient doesn't need to less frequent follow up for the hospitals. So definitely, and is easy to administrations. And this is a degarelix. Degarelix is basically a depot formula also. This is the required reconstitution admission as a deep subcutaneous injection every 28 days with the initial dose of 240 milligram, 2 injections of the 120 milligram, concentration of 40 milligram per ml, and maintenance dose for every month is 80 milligram. The drawbacks only and only is a more frequent dose admission, monthly versus 3 monthly, just like, and longer time required for injection reconstruction. And inconvenience of two injection definitely given. So definitely a frequent follow-up with the antagonist is the main concern only. Otherwise, it's acceptable. Now discuss Dagerlex versus Gozerlin. So there is some studies reference you can say that Sun et al. Published in 19, Ozono and Anderson. They published Dagerlex Gozerlin versus Dagerlex plus Beclutamide also. So they mainly compare the Dagerlis versus Gozerlin, and the primary outcome of the treatment difference for the testosterone suppression less than 0.5. So you can see, and the secondary outcome also you can say there, testosterone levels 0.5. What is the PSA failure in the both arm? So you can clearly see there is a testosterone suppression is quite good with the antagonist compared to the agonist. There is a PSA suppression also quite good with the antagonist compared to the agonist, but there are a long PSA suppression or PSA relapse, overall survival, and the disease-free survival. They all are similar with the Digarelix or Guzalin. You can say antagonist versus agonist. So more or less similar things, but definitely we have our own interpretation. Those who patient, those who have some kind of any obstructive symptom, those who are presented with some kind of spinal cord compression, we have where we have a risk of the flare up of disease through agonist pathway. So definitely we have an option. We can start the antagonist, and definitely you can plan patient fitness as per their comorbidities. So all the direct comparison trial were open label, include patient at the different stage of the prostate cancer, were primarily designed to prove Dagerlis is non-inferior to Gozerlin. So they are all trial is designed as a Dagerlis non-inferior to Gozerlin. Overall treated populations show a comparable reduction in the PSA level, in testosterone suppression level to castrate level, as well as in prostate volume reduction. Patient on Dagerlis show more rapid decline in testosterone and PSA level compared to Gozerlin. However, higher number of Gozerlin treated individuals achieve reduction in testosterone testosterone levels. So that proven by the Ozono trial. Dagerlis could not prove non-inferior to the Gozerlin for the co-primary endpoint also, testosterone reduction as well as PSA reduction. Most of randomized trial compared the 1 monthly formulation of the both drugs. So Ozono and Tombal, they are compared 3 monthly formulation of Dagaresco, but this is not used licensed for the dosing. But they compare the 3 month dose also. The studies had an inherent limitation in the study design, conduct, and some statistical analysis as well as so need some more good randomized trial, open label trial for compare that agonist versus the antagonist. And there is one some quite good study from the Japanese and Koreans groups. So they done a fantastic job for the patients. They started with the patient with the antagonist, and after you can see in this their result, they shift patient to the agonist after some time, and the overall 5 year survival was statistically superior in the group those who have a continuous antagonist compared to those who have changed to the agonist after some times. So definitely this is a very quite good study. You can plan the patient for those who are antagonists, start with the antagonist and can shift to the agonist. So we have an answer. We can shift to the patient agonist whenever any patient on, we start with the antagonist. So shifting patient from the Dagerlis to Gozolin was assured with the improved 5 year survival. And this is the efficacy data where they compare Dagerlex with the Leuprolide, where they use the monthly cycle dose with the same starting dose therapy and maintenance, as we all know about that they are maintenance and starting dose. And the faster testosterone response with the LH antagonist equalize after the 14 days. There is a faster reduction in the testosterone level, but the agonist almost with some time in 2 to 3 weeks they equalize the testosterone level. Faster PSA response with the LH antagonist that also equalized after 14 days. No difference with the anti-flare treatment, but the subcutaneous Dagerlis injection associated with the higher rate of the injection site reaction when compared with the Leuprolide. There is around 40% versus less than 1% local site reaction Dagerlis versus Leuprolide. So this is just when we discuss about the safety data. The only concern in the all study we found that LHRS agonist versus antagonist is Dagerlis have some hypersensitivity reaction or Dagerlis have some local site reaction compared to the agonist. And on the frequent administration of the antagonist as well as time is going on, definitely the risk of the ISR will be high in the Dagerlis arm. So head-to-head comparison also done in this group that done by Ozono and Akasa. They have a ISR reaction like a pain, erythema, swelling is higher in the Dagerlis group compared to the Leuprolide arm. So definitely This is the individual data of that the studies. The ISR incidence was quite high in the Degarelix arm. What about the cardiac toxicity? We have a study about the pronounced study. Everyone knows about that study. They done analysis, or they have some interim analysis as well as some editorial. The safety of the Degarelix versus the leuprolide in the patients, but that study actually uh, somehow due to slower project enrollment, that projected primary outcomes is event enrollment was stopped before the 900 patient plans is planned actually at accrual, but this is stopped earlier. So the cardiac evidence, cardiac safety analysis they done, they found a similar result when they compared the Degarelix and the leuprolide. So on a clinical per se, I say the relative cardiovascular safety of GNRH agonist and antagonist is still controversial. Those who are patient have some atherosclerosis or cardiovascular disease. Pronounced trial is try to analyze the safety of Degarelix versus leuprolide in the patients. Is the first international randomized trial. Those who compare the studies were terminated prematurely with the smaller than the planned number of participant and event, and no difference in the major adverse cardiovascular event was observed at a 1 year between patient assigned to Degarelix or leuprolide. So relative cardiovascular safety at genus antagonism remain unresolved, but some theoretical and some prospective studies also favor that quite in favor of Degarelix or antagonists, like they are quite safe in the cardiovascular disease. So some my clinical practice also, even our or the consultant higher. So definitely they also suggest that we can proceed cardiovascular. Anyone patient have a cardiovascular issues, definitely we choose the Degarelix over the leuprolide. But there is no still we have a no randomized trial or no perfect randomized trial for the that answer. It's unclear, but definitely the safety found similar in the pronounced study. And this study done in
Sir,
also.
kindly conclude your talk in
Yeah,
1 or 2 minutes, please.
so almost we are similar studies. You can say those who have it's all clinical decisions. So what is the incidence of the cardiovascular disease and what is the incidence of diabetes and sudden death MI? So my conclusion for the study is that agonist versus antagonist, we have a quite good evidence for the agonist. But whenever any evidence where we have a risk of flare that will reduce or harm to the patient, we have an option of antagonist. The injection site reaction quite high with the Degarelix and the frequent admission. The cardiac safety is still unclear between the agonist versus agonist. So yes, we have an answer for the agonist versus antagonist. Thank you, sir.
Thank you so much, sir.
Okay, that's all. Again, we are coming to safety.
Asim, sir, kindly mute yourself. Okay, thank you so much, Dr. Abhishek, sir. So next session is urothelial cancer, and I would like to invite Dr. Rohit Swami, sir. He's a consultant medical oncologist, Narayana
Thank you,
Multi-Specialty
Dr. Abhishek.
Hospital, Jaipur.
Yes, sir.
Hello. Thank you, Dr. Abhishek.
Yes, welcome, sir.
Okay, it was very elaborative talk, and you highlighted very much the entire aspect of the hormone therapy in the prostate cancer. Thank you very much for that. And thank you, AstraZeneca, for taking up the session. And now I would like to invite, in interest of time, Dr. Rohit Swami for the next abstract presentation. And Dr. Rohit, are you there? Yeah, so it is. He will be speaking on the double antibody drug conjugate phase 1 trial for the sacituzumab govitecan plus enfortumab vedotin in metastatic urothelial cancer. So now we will discuss 2 or 3 topics in urothelial cancer, and then we will discuss the RCC. Right?
Yes,
So
sir. Good evening, sir.
yeah, good evening.
Yeah.
Doctor.
So I'll be presenting this phase 1 study called DAD, which is a study of combination of double antibody drug conjugates in the metastatic urothelial carcinoma. This is a combination of sacituzumab govitecan plus enfortumab vedotin in metastatic urothelial cancer. So basically, if we come to the background of this study and what is the logic of combining these two antibody drug conjugate is that ki SG and EV Both have the different payloads and both have the different targets. Like SC targets TROP2 and has the SN38 payload, which is an irinotecan metabolite, and most common side effects are myelosuppression and diarrhea. On the other hand, EV targets Nectin-4 with a MMAE payload, and most common adverse effect with EV is neuropathy, rash, and hyperglycemia. So there is a difference in targets. There is potential synergy in payloads, and non-overlapping toxicities are there. And at present, currently, these drugs are used sequentially. And this was the first phase 3 study to determine the dose of the combination, which can be the maximum tolerable dose and which should be the recommended phase 2 study dose. Next slide, please. So this study design has three different drug levels, dose levels. So dose level 1 was SG 8 milligram per kilogram and EV 1 milligram per kilogram. Dose level 2 was escalation of EV by 1.25 milligram. And dose level 3 has the escalation of both SG as well as EV. SG escalated by 2 milligram per kilogram and EV escalated by 0.25 milligram per kilogram. And there was also option of dose de-escalation, which was dose level -1, where SG was 6 milligram per kilogram and EV was 1 milligram per kilogram. Eligible patients on metastatic urothelial carcinoma who had progressed on platinum-based chemotherapy and immunotherapy, or has progressed on one line of cisplatin-based therapy, or are cisplatin ineligible. The patient with CNS mets or ongoing toxicities is grade 2 or more, or prior treatment with HG or EV were not enrolled in this study. Primary endpoint of this study was to look for dose level toxicities after cycle 1, like neutropenic fever, thrombocytopenic bleeding, grade 3 neuropathy, non-grade 3 hematologic toxicity lasting more than 1 week or requiring 3-week treatment interruption. Secondary endpoints are overall response rate, PFS, overall survival, and median follow-up of this study was 15 months. Next slide, please. Coming to the baseline characteristic of study population, median age was around 70 years. Around 70% of patients were male, and 83% of the patients were Caucasians. All the patients had ECOG PS 0 or 1. Primary site 70% was bladder, and around 30% was upper urinary tract. And pure urothelial carcinoma were around 70%, mixed urothelial were around 30%, and around 50% patient had received 2 or 3 to 5 prior lines of therapy before enrolling in this study. And 95% patient received prior immunotherapy, 95% patient received prior platinum-based chemotherapy, and majority of the patient had 75% had lymph node metastatic sites. Around 26% has bone and liver also. Next slide, please. So coming to the maximum tolerated dose, in the dose level 1, there were 2 neutropenic fever as well as grade 4 sepsis. And dose level 2 had only one patient who had the delay in treatment because of toxicities, whereas dose level 3, where both sacituzumab as well as EV dose was increased, there were 3 febrile neutropenia, mucositis, and there was delay in treatment. And one patient in dose level 3 didn't receive day 8 of the therapy, so that patient was not available for dose level toxicities. Next slide, please. And coming to the adverse event, most common adverse events were diarrhea, anemia, as well as fatigue. But most common grade 3, 4 side effects were neutropenia, followed by anemia and diarrhea. Next slide, please. One patient had grade 5 pneumonitis, which was related to EV. So, coming to recommended phase 2 dose, so it was dose level 2, which was recommended to be studied in the phase 2 study. And dose level 1, around 4 patients had the dose reduction by 1 level. In dose level 2, around only 2 patient has the dose reduction. And in dose level 3, around 3 patient has dose reduction. Next slide, please. Coming to efficacy outcome, so there was 70% overall response rate, with the CR was seen in around 3 patient, PR in 13 patient, stable disease in 3 patient, and 3 patient had progressive disease. 12-month PFS percentage was around 41, and 12-month overall survival percentage was around 85. And at the median follow-up of 15 months, 9 out of 23 patients were still demonstrating ongoing response. Next slide, please. So coming to the conclusion, DAD was the first trial who demonstrated that there is a safety of combination of these two antibody drug conjugate, SG and EV, and maximum tolerated dose was SG, which was dose level 2, SG 10 milligram per kilogram, EV 1.25 milligram per kilogram, day 1 and day 8 of 21 days cycle. But recommended phase 2 dose was SG of 8 milligram per kilogram and EV of 1.25 milligram per kilogram with GCSF support. No new safety signals were observed in this phase 1 study for both the HG-EV combination as well as separate HG and EV, and it demonstrated overall response rate of around 70%, and 9 out of 23% patients were still having response after the median 15-month follow-up. And now ongoing studies are further continuing to investigate SG and EV alone or a combination with pembrolizumab in urothelial cancer. So combination of SG and EV can be a promising second line or third line therapy in metastatic urothelial carcinoma who have progressed on platinum-based therapy as well as immunotherapy. Thank you. Thank you, everyone.
Thank you so much, Rohit sir, for your presentation.
Yeah, thank you.
Thank you, sir. So now next speaker is Dr. Kripa ma'am. So he's a consultant medical oncology, Hospital Indo-American Cancer Hospital and Research Institute, Hyderabad. It's over to you, ma'am.
Yeah. Can you please share the slides?
Okay, give me 1 second, ma'am. Is it visible, ma'am?
Yeah. So thanks for the opportunity, Asim Sumar sir. So today I'm discussing regarding ambassador trial. One of the two trials which are really important in this ASCO was one is checkmate trial nivolumab, which is in the adjuvant setting, and second is ambassador trial. And nivolumab got an accelerated approval for the nivolumab, and pembrolizumab is still awaiting for the approval. So ambassador trial is a phase 3 trial of pembrolizumab versus observation as adjuvant therapy for high risk muscle invasive urothelial carcinoma. Next slide. So the current standard of care for muscle invasive urothelial carcinoma is a radical surgery plus or minus neoadjuvant chemotherapy. Many patients are not eligible for neoadjuvant chemotherapy or have persistent disease after neoadjuvant chemotherapy. Cisplatin-based adjuvant treatment improves disease DFS, but it's not recommended post NAC. Pembrolizumab is PD-1 checkpoint inhibitor approved for use in many tumor types, including some specific indications for urothelial carcinoma. It's a second-line metastatic setting. There is a single-agent approval is there for urothelial carcinoma as well. This is the only interim analysis of the phase 3 trial. It's not a final analysis. So after the final analysis, maybe like a pembrolizumab will have a good approval. So it's a phase 3 trial comparing pembrolizumab versus observation as adjuvant treatment for high-risk muscle invasive urothelial carcinoma. Next slide. So it's an adjuvant treatment. So it got stratified as per PD-1 negative, PD-1 positive. Neoadjuvant chemotherapy, S versus no. Pathological stage, that's the PT2, N3, sorry, PT2, T3, T4, N0 versus TA, N0 versus pathological T4B, NX are node positivity. So specifically here, like from T2 onwards, we can include any node positive can be included, or positive surgical margins also can be included. So the patients with muscle invasive urothelial carcinoma who have undergone radical cystectomy, nephrectomy, nephroureterectomy, or ureterectomy within 4 to 16 weeks of enrollment, we can start pembrolizumab. Even the post-neoadjuvant chemotherapy also got allowed. This is the post-neoadjuvant chemotherapy. The PT2 node positive or margin positive is eligible, or cisplatin ineligible are declined, and if the upfront surgery with PT3 node positive, margin positive is included. Here, pembrolizumab 18 cycles versus observation. The stratification of PD-1 positivity is CPS more than 10. In the nivolumab, that trial it's a more than 1 PD-1. Here it's a CPS more than 10. The primary endpoints are OS DFS, secondary endpoints are OS DFS and PD-1 positive and PD-1 negative cohort safety. Next slide. So the stratification regarding the age, race, gender, pathological stage, PD-1 positivity, primary tumor that's upper tract, urethra, bladder, and histological variant of mixed urethral histology, excluding neuroendocrine, is like got matched well. This is the pathological stage, the positive surgical margins, node positivity, P2, T3, N0 or NX, P4, N0, NX, like everything got properly matched. But PT, NE, and node positive, the node positive group constitutes substantial, that's 50.9 staggering amount, and mostly it's a male population which constituted. Next slide. So if you see this, the DFS and intention to treat population and patient by age and epoch PS, the DFS is 29 months versus 40 months with a hazard ratio of 0.69, and ages, epoch status, like everything, the all groups got a good benefit with pembrolizumab addition and the adjuvant setting compared to the observation. Next slide. So disease-free survival by neoadjuvant treatment. So neoadjuvant received versus neoadjuvant no. So both groups have an added advantage. Whoever received neoadjuvant or like whoever underwent upfront surgery, they have a good benefit. So all pathological stages got a good benefit. Only the T4N0 NX, like the hazard ratio is 1.12, means like there is absolutely no benefit. So have undergone. Maybe like this is the only one where hazard ratio is like not so good. Positive surgical margins got a very good benefit. And also node positive group as well as T2 as a upfront surgery with the T2 T3 also good benefit. But somehow the reason the T4N0 or NX like, don't have a good benefit, though the number is very small. The primary lower tract got a good benefit. The hazard ratio is 0.63. PD-1 positive versus negative, there is not much difference. In fact, the PD-1 negative group, like it's the only trial I would say, in the nivolumab arm, PD-1 negative group has not much benefit. There is a marginal benefit is there. But in this ambassador trial, pembrolizumab has shown a benefit even in the PD-1 negative population as well. The DFS is 9.1 months in observation arm versus 22.1 months in the PD-1 negative group. And positive, yes, of course, it's 32.8 versus 20.7. But both groups got a good benefit, but it's like unexpected to see a benefit in PD-1 negative population as well. Next slide. So OS, it's a very immature. So almost both are having an equal outcome at this point, though we know that it's an interim analysis. Maybe the final analysis will have a conclusion, and nivolumab OS also got updated. There is a good benefit in the nivolumab trial, but pembrolizumab it's only just interim analysis. So maybe the approval after final analysis will be awaited. Next slide. So here the PD-1 positive versus negative, neoadjuvant versus like if you see the OS also having a decent hazard ratios. Only the upper tract that we don't see much benefit. With the lower tract, there is a good benefit is there. So the OS like across, if you see the hazard ratio is not significant because it's absolutely almost the curves of bang on. So we have to wait the final analysis. Next slide. So other systemic therapy, any therapy, checkpoint inhibitor therapy, chemotherapy, like predominantly if you see the any therapy, post-DFS and pre-DFS, pembrolizumab versus observation. So definitely pembrolizumab group has a good benefit. So it does not take patients who withdrew consent actually, but usually any systemic therapy patients also received a good benefit with addition of pembrolizumab. But the DFS benefit got substantially projected, but OS benefit is yet to be seen. Next slide. Adverse reactions, like grade 3 adverse reactions are slightly higher in pembrolizumab than 38.6, but it's not clinically significant. There is no significant grade 4, grade 5 reactions, be it hematological or non-hematological. Next slide. So if you see this like any grade 3, grade 4, absolutely grade 4, not much difference. Is like grade 3 only few people got affected. Any grade like yes, of course. We do see fatigue, diarrhea, and everything, but grade 3, grade 4 reactions are not significant. That suggests that it's a clinically well tolerated and it can be offered to most of our patients. Next slide. So what are the investigator conclusions? There was a significant improvement in the median DFS with adjuvant pembrolizumab versus observation. For patients with high risk muscle invasive urothelial carcinoma, thus meeting primary endpoint, the DFS is 29 months versus 14 months with observation. Similar efficacy regardless of the PD-L1 expression level. In nivolumab, PD-L1 negative, there is no benefit, but here there is a benefit. The OS endpoint was numerically higher with pembrolizumab versus observation, but was not statistically significant at this interim analysis. Investigator noted that more patients in observation arm received checkpoint inhibitors post DFS, potentially affecting the outcome. So pembrolizumab safety was consistent with the previous reports. So here, like most of the people received pembrolizumab. So in OS, like we're really not sure the carryover effect will be there. So investigator conclude the data from ambassador trial support adjuvant pembrolizumab as a treatment options for high-risk muscle invasive urothelial carcinoma. With this, I conclude my talk, and thanks to organizers once again.
Thank you, Dr. Kripa. It was a nice talk. And did you find any place of in your practice of this pembrolizumab in muscle invasive cancer?
Cisplatin eligible for sure. I would like to offer nivolumab or pembrolizumab, sir, because we really can't give any effective agent in them. For sure, I will offer. Even cisplatin ineligible also I do offer, but ineligible patients, but definitely this will be the best option, we would say.
Yeah, and sometimes especially in the muscle invasive urothelial cancer, PFS is also a very important landmark.
Yes, sir.
Yeah, so
And also in this one, OS we can't really say, sir, because most of the people receive checkpoint inhibitors in
crossover.
observation
Yeah.
arm. Crossover is that we really don't know. But definitely this will be a promising option, sir.
Yeah, and now I guess the next speaker will speak like many of the patient won't go for the second line therapy. So in the first line, DFS is also very important thing, right?
Yes, sir.
Yeah. So thank you, Dr. Kripa, once again. And now I would like to invite Dr. Akhil Kapoor. He is the professor in Medical Oncology Department, Tata Memorial Hospital. He is a good friend of mine, and he will be speaking on the sponsored session by Mark. And the topic is management of the advanced urothelial cancer. And Akhil, we were missed you, and we were remembering your conference on the Shivratri this year also. So me and Tarachan, Dr. Tarachan were talking like last year we were there in the Banaras.
Yeah.
So at
Yeah.
least once in 2 years you should organize that.
Sure,
That's what
sir,
I
sure,
say.
sir. Next year, please pack your bags in advance.
So very few conferences about the people are waiting actually. So
Yes,
one
sir.
of yours.
Thank you, sir. Thank you, sir. It was the team effort due to Mishra sir, Dr. Anuj, and the entire team. So we
Over
could
to
do
you.
it.
Yeah.
Yes, sir. Thank you, sir. So now we are discussing about the management of advanced urothelial bladder cancer, and I think we have found that there are now some multiple options are coming up. We have some data of Gemcis Nivo. We have data of the EV plus Pembro, which seems to be very promising and lucrative. But let's see what we have presently and what could be the best present option, which is already available to us. So we know that a significant number of patients are platinum ineligible, actually cisplatin ineligible, but some of these are actually carboplatin eligible. That is why most of the time in our real practice, we end up using gem carbo much more frequently than gemcis in the real practice. So if we see out of 100 patients who come to us for opinion for systemic therapy for advanced urothelial bladder cancer, 10 to 20%, I will say, they do not receive any treatment because of poor performance status, and they have to give supportive care only at the baseline itself. Then comes cisplatin eligible patients. They will form close to 40% of the total cohort. Then rest 60 to 70% patient will be actually only carboplatin eligible, not cisplatin eligible. So that is where we utilize most of the time gem carbo, and then we think of adding some treatment in the maintenance setting. So I always say that urothelial bladder cancer behaves somewhat like small cell cancers, where the response is very good initially to the platinum, but what happens? The response dies out fast. So the patient will tend to give response after 2 to 3 cycles, but after 6 to 8 cycles, when we are reassessing the patient, we see that the patients are now progressing. And also, if we have completed 4 to 6 cycles, then most of the time, if we keep the patient on follow-up on close observation, most of the patients will progress within 2 to 3 months, and then we have very limited options, including immunotherapy, but the responses are not very good. And also, We have utilized most of the treatment options which are being discussed here. We have imported sacituzumab. We have utilized erdafitinib on compassionate access programs. So we have quite a lot of experience in treating advanced urothelial bladder cancer, and that remains a disease with which we remain fight for patients surviving somewhat longer. So median PFS overall is 6 to 8 months in the second line specifically, and overall survival overall seems to be just 12 to 13 months actually. So this is what we discussed. There are some other options. MVAC, though very commonly discussed and in the academic forums, hardly we see patients very fit for MVAC in the real world settings, especially in our area. We got some inputs that patients who are living in the hills like Rishikesh and other areas, they are somewhat fitter and are able to tolerate MVAC, but not, at least not in our settings. So this is the treatment options which we can see. There is an option to wait and watch after cisplatin or carboplatin eligible patients. When the patient develops disease progression, initiate second line therapy. This is wait and watch option. The switch maintenance option, which we will be discussing today, primarily it chemotherapy with cis or carbo, then switch to IO maintenance, and then initiate second line therapy if the patient progresses on IO maintenance. There's another option of chemo plus IO followed by IO maintenance, then initiate second line therapy. So primarily, third option was previously thought to be out of question because both a TIZO study was negative and also Pembro study was negative. But later, new time, the new data has come with this GemCis only, not carbo with NIGO. But as I discussed, these form a very small number of the patient in our settings. So wait and watch approach, we know that these patients do very poorly. Actually, what happens, the patients who are kept on observation, 50 to 60% patients are unable to receive next line of treatment. That is what happens. These patients progress really very fast and they are able to receive only supportive care if they progress. This is the situation. This is the switch maintenance data which will be coming up. So chemotherapy in that induction-like treatment, which decreases the tumor burden, releases the antigen into the circulation, then utilizing avelumab maintenance as a switch maintenance treatment option. And that has shown significant benefit. And this is the proof of the concept, and the randomized phase 3 trial is available, Javelin Bladder 100 data, where you have utilized induction chemotherapy. A patient was kept on treatment-free interval of 4 to 10 weeks. And the patients who had not progressed were randomized 1:1 with 10 mg per kg avelumab 2 weekly versus supportive care alone, with primarily endpoint of overall survival. This is what I wanted to highlight. Very few studies in metastatic and advanced setting have the courage to design a trial based on overall survival, because we keep on discussing that in advanced setting, it is difficult to get overall survival benefit. Some PFS benefit, even if it is of 1 or 2 months, they might prove to be statistical significance, especially when we are taking a patient population of 500 plus. And on that basis, most of the drug get approved. But here we see a trial which is pragmatically designed and allowing both cisplatin and carboplatin, which is the real world scenario that most of the patients are able to receive carboplatin also, not cisplatin. And this study is able to answer this question. If we see the data, median overall, this is measured from the start of the therapy most of the time. And the data seems that the patients are able to reach close to 30 months overall survival when we discuss from the start of the therapy. And the improvement in OS is from 20 months to close to 30 months. So absolute improvement of 10 months instead of 20 months. This seems to be actually very huge, close to 1/3, 93% reduction in the risk of death. This is huge actually. We have seen utilized Bavencio already in our practice. Most of us have utilized, and we know that apart from some infusion reaction in the initial, these doesn't seem to have much toxicity. And there is a good data from the ESCO June 2024 update, Avinance study. This is one of the largest real world data of 595 patients, which have shown that data of very good outcomes. If you see, unprecedented median overall survival of 40.8 months was actually achieved for the patients who received platinum chemotherapy followed by avelumab maintenance and then second line enfortumab vedotin. So this we keep on discussing from the availability of EV plus pembro data. When should EV be used? whether EV plus sacituzumab is a good option in the second line and beyond, whether EV should be used upfront. I think it is very important to understand that EV is a toxic drug. It has significant peripheral neuropathy. You cannot continue it for very long. So that's the main problem. The good thing about the immunotherapy drugs is that they seem to be much well tolerated than any other treatment option. This is the third trial which we have just discussed actually, that Atizo and Pembro data were negative. Gemcis Nivo data has come as positive, but median overall gain is over control arm is just 2.8 months. That is what we need to understand. This is very important. Here at one side, you are seeing a patient with good long-term follow-up, and the outcome is 10 months overall survival improvement. And at the same time, we are seeing another data set where there is improvement of just 2.8 months, and it is good getting approvals. So this is what we need to understand. This is the Checkmate 901 design, Gemcis Nivo versus Gemcis alone. You can see Nivo 360 milligram, but utilized 3 weekly, 300 patients in each arm. Primary endpoints were combined composite endpoint of OS and PFS. And if you see the Bavencio study versus nivolumab study, in nivolumab study, Gemcis followed by avelumab maintenance was received by only 9 patients in the comparator arm, while in the Bavencio study, best supportive care followed by immunotherapy received in 74% of the patients. So if we are discussing about the overall survival, these things matter a lot. If the nivolumab study should have been designed in a way where the patient should have received Gemcis followed by avelumab versus Gemcis plus nivolumab, then it would have been some meaningful comparison. But I don't think the comparison is justified when we are utilizing only Gemcis and then keeping the most of the patients. 91% patients of the control arm are not getting the standard of the care treatment presently. So that is the main problem. In the Bavencio trial, that is Javelin Bladder 100, the patients who were on the control arm, 74% patients received who received some treatment received immunotherapy as the second line of treatment. That clearly highlights the utilization of correct treatment options in the control arm, because weakening the control is the most common policy to utilize improve the outcomes in a trial, and that is what we see. And also what we see, if we are seeing the PFS with Gemcis versus Gemcis Nivo, the PFS benefit is just 9 days over. You can understand this 9 days of PFS. It seems that it is doesn't seems to be feasible in our setting. For 9 days benefit, you will give treatment with nivolumab for close to 6 to 7 months while on patient is on chemotherapy. I don't see any meaning for the same. At the same time, the benefit, as we discussed, is just 2.8 months with OS. So it's very clear that this study, though it is selecting better patients, it is selecting only cisplatin eligible patient, not carboplatin. Forget about carboplatin eligible patients. So we have now this data available, and we can see that if with the utilization of enfortumab vedotin in the second line, the data is going towards 40 months of OS outcomes as compared to the usual outcomes, which was expected to be 30 months. And the other data is also available, which is giving a median OS outcomes of 20 to 21 months only. This is the another data of continuation maintenance, that is Durva plus Tremi, that was in a negative trial, Pembro plus lenvatinib, but also a negative trial. Now comes EV plus Pembro data, which is very positive trial, and it has got a standing ovation at ESMO 2023. Let's look at some data and points about this EV 302 and Keynote 839. So again, 900 patients close to enrolled. These patients were stratified by cisplatin eligibility versus ineligibility. PDN were low and high, liver mets present or absent. If you see, the overall survival difference was risk of death was reduced by 53% in patients who received EV plus Pembro. So it seems to be good data, 16 versus 32 months. So outcomes survival of overall survival is doubling, but it is from the baseline itself. And what is you are seeing that a significant increase in grade 3, grade 4 toxicities. You can see a significant number of patients are developing skin reaction. Grade 3 or more is also 16%. A lot of peripheral neuropathy, 63% patient developing any grade neuropathy, 7% developing grade 3 or more neuropathy. So that is worth considering. So what will be the quality of life of the patient even if they are able to survive somewhat longer with the approach, but still overall survival is still lower with the data which is available with EV plus pembro. But yes, it needs to be matured a lot. It is a very immature data till now. So it seems that the Avenant's approach might be the best possible approach till now. Even when enfortumab vedotin becomes available, enfortumab will be available after 6 months in India, and expected outcomes by that approach seems to be close to 40.8 months. And if we see the data and the guidelines, even in the version 2024 one guideline, you see GEMSIS followed by Oluva maintenance or DDMVAC followed by Oluva maintenance seems to be the preferred approach. And EV plus Pembro has already come in the guideline, but that remains a category 2A recommendation, not a category 1 recommendation. GEMSIS Nevo has also come, but it is again a category 2A recommendation, not category 1 recommendations. So even the NCCN agrees that the data of GEMSIS or GEMCarbo Nevo is much stronger, and that is meant to be a long-term fighter, and that is why it has been given category 1 recommendation apart from all the other options. So thus, to summarize, platinum-based combination followed by avelumab maintenance seems to be the best possible approach. You can utilize enfortumab vedotin in the second line and beyond. Sequencing of the available agents remains the key, and real-world data are also consistent with the data which we got from Javelin Bladder 100. With this, I would like to stop here. Thank you, Ashim sir, for giving me this opportunity.
Thank you, Akhil. So, in the setting of this urinary bladder cancer, imagining the 30 or 40-month survival is just difficult to imagine. But now, I guess in coming future, it will be like lung cancer, where we are going for the 39 or 40-month survival at least.
Yes.
And in the target positive tumors, it may be like 5 to 6 years.
Correct.
So it's nice presentation again. And you have the information like enfortumab vedotin is going to approved or available in India 6
Yes,
months
yes.
down the line.
It is likely to be in the third quarter of this year itself. So after 4
Okay.
months from now.
Yeah. And I guess it is oral or IV?
No, IV drug.
IV. Okay, okay. Maybe I guess in real world setting, dosing schedule might change
Yes, sir.
if the
We have
toxicity is high.
imported enfortumab and utilized in one of our patients.
Yeah,
So it causes a significant neuropathy. Even the combination of EV plus acituzumab, the same problem will be there. EV itself is causing neuropathy. Acituzumab also causes neuropathy. So that will be a problem.
Yes, acituzumab is it is causing the pulmonary complications also, I guess.
Yeah, completely agree. ILD is one of the important
Yeah,
complications.
thank you very much, Akhil. And
Okay,
okay, so we will move on to the next session. It is sponsored by Zydus, and the speaker will be Dr. Jitendra Pehlajani, a very charming medical oncologist. And every time you talk with him, it's very nice to hear his thoughts. So, Dr. Jitendra Pehlajani, he is consultant medical oncologist in Shelby Hospital, Jaipur. No, in
और आप
SCG
तो ऐसे ही
Hospital.
बोलो
SCG Hospital. Right? Jitendra, you are
तरुण
so
तरुण जी के साथ
friendly.
तो मैं 2 साल छोटा हूँ अभी भी और 2 2.5 साल छोटा
Okay. So the talk will be on the role of enzalutamide in metastatic HSPC and metastatic CRPC. So Dr. Jitendra, over to you. You are
थैंक यू
out
सो
of
मच
Jaipur, Jitendra?
नहीं नहीं सर कोई पेशेंट आया हुआ था उसको देखने आया था ट्रैफिक में फंस गया तो रुक गया रास्ते में
Oh,
so
okay, okay. This is
so
very
we'll
long you
manage
are
the
in the
him
car. So Jaipur is
yeah,
not
yeah
that big.
I am in the car in Jaipur itself one
Okay.
patient follow-up hypercalcemia landed in emergency had to go this is
Yeah.
how it is thank you so much Asim boss and Jidus for giving me this opportunity. So as we all know, the prostate cancer was usually used to be a hormone manipulative disease. We used to give single agent, you used to orchidectomy, then we came for GnRH, GnRH antagonist, agonist. Then now we are spoiled with a lot of choices. Abiraterone is there, enzalutamide is there. and apalutamide is also a new drug in the kitty. Now we are coming with combination with triple drugs, with PARP inhibitors. So let us figure out how we can use this molecule better. So today I have given the opportunity to talk about enzalutamide, how we can use best in our routine practice. So we'll sail through with this. Next slide, please. So, first coming to the metastatic castration-resistant prostate cancer. Just for the simple definition, any prostate cancer which is not sensitive to the hormone manipulation is metastatic. Basically, androgen depletion is basically castration-resistant prostate cancer. So this is how the hierarchy looks of a prostate cancer. Usually it comes as a local disease. Then we treat it. There can be a biochemical recurrence. Then it is initially a castrate-sensitive disease after adjuvant treatment. Then there can be radiographic metastasis, usually which is bone, which is cause a painful disease. And usually castration-resistant prostate cancers are painful. That's why the patient comes to us. Initially, also patient can come with the metastasis, and the treatment will be surgery or radiation for local disease, androgen depletion for whole course of the treatment, whether it is surgical or medical, and we have host of agents to deal with the things like I have discussed abiraterone, enzalutamide, apalutamide, combination of dosi, abiraterone, dosi, dilutamide, cabazitaxel, you name the things, and we can use it as a systemic treatment. Next slide, please. So coming to what the what the guidelines say for a patient who has prostate cancer, which is castration resistant, with no prior systemic therapy, we have three primary agent and many combinations available. So usually what we give, since prostate is a disease of aging, so usually we give hormone manipulation in form of ADT plus abiraterone, maybe if disease burden is high, docetaxel on the basis of stampede, and maybe enzalutamide. And we have combination on the basis of HRR. And if in unfit patient, bone high disease, we can go for radionuclide therapy and other measures. Next slide, please. So coming to the data, what data suggested, if patient is having AR inhibitors like androgen receptor inhibitors, which is primarily abiraterone and enzalutamide with plethora of data, the risk of death pre-docetaxel is reduced much more, like 17 to 19%. As we can see the data of abiraterone study, which is 34.7 versus 30.3 months, versus previous study, which suggested Enja versus placebo, it was 36 versus 31 months. So both the studies were positive in a metastatic castration-resistant prostate cancer prior to exposure of the docetaxel. Next slide, please. So how to choose these agents when we are using in the first line? So abiraterone has its own side effect like hypertension, edema, hypokalemia, liver dysfunction, and you have to give concurrent prednisolone to it. So maybe again lipid profile will be deranged, your metabolic parameter will go high, and these are the things which bother in the patient who are actually old age. We will see how many patients we can see in old age. Enzalutamide at the full dose is difficult to give for many elderly patients, as I feel, that fatigue, hot flush, and GI toxicity. These three things are more common. Drug-drug interaction with CYP3 inhibitor, although manageable in current scenario, you can check the interaction checker and you can do. Docetaxel, again, it has shown a overall survival benefit, but you need a fit patient, a good performance status, a high disease burden. But as all other chemotherapy, it needs to justify the fatigue, the peripheral neuropathy, and obviously the risk of neutropenia. But with the expertise available now in the cities, cytopenias are less of a problem rather than the fatigue. Right, please. So coming to the monitoring part of these drugs like hypertension, edema, fatigue, electrolyte imbalance, elevated LFTs. So we have to see the examination. Obviously, we have to do CBC with differential. I think prednisolone and abiraterone has less to do with it, but I usually do for a month or two for initial stages. Later on, it is not mandatory if I am giving abiraterone alone. Chemistry in the form of LFT and potassium, I usually do frequently, like every fortnightly in for 1 or 2 months, and then every monthly. And PSA obviously for response assessment. And usually we do 4 to 6 months scan also, at least after first few doses of abiraterone. Next slide, please. So hypertensions are usually well managed if patient is not hypertensive earlier, but if patient is hypertensive, they usually have a propensity to have more antihypertensive medication use, and prednisone should be taken because it will cut off that cortisol RS system activation, and then there will be no hypertension. So good communication with other medical providers are the key. And probably now we are using lower dose of abiraterone with food, fatty food. That's why the probably side effects are getting lesser and lesser day by day. Next slide, please. So coming to the enzalutamide, so it is given as 160 mg oral OD single, means you have capsule also, tablet also, and now you have syrup formulation also for old age patient. So we can reduce the dose 120 mg. Usually most of the patient tolerate 120 mg more better than 160 mg. But 50% patient do need some sort of dose reductions in enzalutamide also. Next slide, please. So coming to the available formulation, the primary drug which was approved was capsule, which was 40 mg. Gelatin capsule, it was very large in size, as you can see, 2 centimeter. So later on, the tablet coated was available, which was almost half of the size of the capsule. But now we have 80 mg tablet and liquid enzalutamide, probably, which is my favorite of giving it to elderly, because having a 4 to 2 tablet a day, it's easy to get a 5 ml syrup. And when you are having polypharmacy or patient who has stroke in the history or something like that, so probably liquid formulation will be helping us in giving more patient the benefit of the treatment. Next slide, please. So coming to the comorbidity, because as we know that prostate is a disease of old age, it's usually common in the 60 plus. So we have almost 10 to 15 comorbidities which can be there, as we can see this within the spider chart, and almost half of the patient will have some sort of comorbidities, and hypertension is the most common. And somehow due to disease burden, due to pill burden, due to the lack of remembrance, probably they can be not adherent to pill burden. And so we have to ensure that patient should take all the treatment properly. Next slide, please. So having said that, taking 4 triple is difficult. So there is biochemistry study of liquid enzalutamide versus innovator enzalutamide, and we can see that innovator and the liquid generic enzalutamide, the ASU curve is almost parallel to each other, although the P max with the innovator is slightly higher. But still the area under curve is almost similar with both the drugs. So we can actually give this drug safely and effectively to our patient. Next slide, please. So these are the common adverse events like hot flash, fatigue is the common. What I see most is mucositis, diarrhea, oral ulceration, nausea is more common. Fatigue and muscle weakness is probably common to all hormone therapy what we see. So frequent blood pressure examination, and one more peculiar thing which we should ask to our patient is dizziness, because dizziness is more common, and the patient who are frail, probably they have a risk of fall. So 3-minute mini cog is also indicated, means patient has to alert, stand up and walk. So these all tests we can do in our OPD to assess the dizziness component and to our patient. Next slide, please. So these are the management issue which we all know. Next slide, please. Coming to the data, what the data suggests, if so this is the phase 3 trial of first line PARP inhibitor in a castration resistant prostate cancer, like oraparib versus placebo versus talazoparib enzalutamide versus enzalutamide. So we have 2 studies, olaparib with abiraterone, which has already approved in May 31st, 2023, and olaparib is available with uh, various companies now. So probably we can use it more frequently, and we can see the hazard ratio is 0.23, almost 77% risk reduction of progression, which is very huge still if it is a prostate cancer also. Similarly with talazoparib data, but this drug is probably will going to available in near future, so we can do a comparison and use it in India also. Next slide, please. So coming to, if patient has taken docetaxel prior to the novel hormone therapy, this patient was having hormone sensitive disease, and maybe patient had a high burden disease, so he was exposed to docetaxel. Still, Betatron and enzalutamide still have a data. We'll see the data how it goes. Next slide, please. So if we compare the OS pre-docetaxel versus post-docetaxel, as we can see that post-docetaxel probably the effect is not that much, but still both the drugs are effective post-docetaxel, and they do have enough data to support and use it, like in AFFIRM study and 301 study. Next slide, please. Next slide, please. So coming to the hormone-sensitive prostate cancer, as we all know that Arches trial is still uh, having data was immature, but the final data is yet to come for OS. Still, the PFS data was improved and it was approved in hormone-sensitive prostate cancer setting. In the phase 3 Titan trial, apalutamide has shown that ADT improves both RPFS and OS in metastatic hormone-sensitive prostate cancer. So the enzyme study was sought to determine the OS benefit of adding the enzalutamide to the ADT. Next slide, please. So here the three-drug agent was used. So enzalutamide was given and it was compared with bicalutamide, nilotinamide. So probably this study land back around in 2016 because this was a 3-year follow-up published as an abstract in 2019. So probably at that point in time, those agents were used as a baseline in 2014 to 16 when the study was planned. So it was a phase 3 study comparing enzalutamide with other mide agents, and patient were hormone sensitive. Next slide, please. So here we can see almost 500 patients in each arm. All the arm were well managed. 50% patient were high disease volume, 50% was low disease volume. And next slide, please. So here we can see that almost 80% patient was alive at 3 years of follow-up in the enzalutamide arm. So almost 8% benefit of overall survival, which is primary endpoint of this study. Next slide, please. So as we can see that enzalutamides fare better with other agent. As we know, it's a second generation agent with more potency. So hazard ratio for PFS was almost 0.39 and time to clinical progression was also better, which is 0.40. Next slide, please. So here we can see that when testosterone suppression plus docetaxel was given in the highest patient along with enzalutamide, there was a difference in PFS, whether it was given with docetaxel or without docetaxel. If you compare with overall survival, with docetaxel, the overall survival fades away because docetaxel works with different mechanism of action and it has its own driver for overall survival. But when docetaxel was not used, it also did produce some sort of overall survival. So with docetaxel, probably the overall survival benefit was not there for enzalutamide. Next slide, please. So early docetaxel when we used, so there were 74 means early docetaxel was given in 74% of the patient, and high disease was 71% of patient, and almost all were well balanced. Next slide, please. So 65% of the patient who received more than one cycle of docetaxel had continued treatment for 62 months. So there was definitive PFS benefit. On the contrary, 34% without enzalutamide and 62% with enzalutamide. Adverse events were more in the enzalutamide arm, and the cause of discontinued treatment was more adverse event in enzalutamide. Otherwise, all the other side effects or all the other reasons were more common in the control arm. Next slide, please. So the side effects were more if it is grade 3 in enzalutamide arm, although grade 1 or 2 side effects were almost similar in both the study group. Hypertension was more in the enzalutamide arm. Fatigue was, as we see that this is a more potent agent. So the side effects, which was class side effect of hormone therapy, were more. Dizziness was a worrisome side effect. It was almost seen in 5% of the population. So we have to keep in mind. And seizure was also seen in one patient. Next slide, please. So as we can see that when you use anti cytotoxic chemotherapy drug, the neutropenic fever will be more. The neuropathy will be more when you use it along with docetaxel, and other side effects were almost same. Next slide, please. So docetaxel was given at the start of treatment. Starting was given in 53% patient, and more than one life prolonging therapy was given in 67% of the patient in enzalutamide arm as patient progressed later, and in the non-enzalutamide arm, almost 85% patient received the other therapy. Although almost half of the patient in the control arm received enzalutamide, and other 30% patient received abiraterone in that study. Next slide, please. So enzalutamide demonstrated improved survival compared with the standard agent at that point in time. 36% OS benefit was almost 8%, and the OS benefit was despite high volume or low volume disease. Increased toxicity was shown with addition of enzalutamide, as we all know that this drug is potent and there were side effects. So this study investigator concluded that enzalutamide is an appropriate option for man with metastatic hormone sensitive prostate cancer starting on ADT. Next slide, please. So diagnosis can be there at various stages, as we have discussed. That we have earlier localized therapy, then we used definitive therapy, then there can be a biochemical relapse. We should identify the metastasis. If there is only local recurrence, probably it is metastatic hormone sensitive prostate cancer. We can start ADT, and if the criteria are met for hormone resistant, means the prostate doubling time is lesser, then probably it is castration resistant prostate cancer, and then we can use all the agents which we have discussed. Next slide, please. So coming to the end, so we have various agents in our kitty, and we can use these agents wisely to treat and cure control prostate cancer for a longer time. Thank you for your listening.
Thank you, Dr. Jitendra. Thank you. And now I would like to re-invite Dr. Deepak Shukla for
So,
complete speech.
firstly, I would like to inform technical support. Kindly please pause the session, recording and live session, please.
Thank you. So I would like to share my slides. Just a minute. Okay.
Sir, your slide is not visible properly. Can you please?
Now it is visible. Gitika, is it visible or not?
Sir, screen is visible, but your PPT slide is not moving.
See that now it is moving.
No, no, sir.
Just a minute then. I will stop sharing.
Yes, now it's moving, but make it full screen.
Just a minute. I will stop sharing, then I will again reshare it. Now it is moving. Gitika? Okay, or other way you can play it.
Sir, can you please share your PPT slides on my WhatsApp?
Okay, just a minute. Shared. Geetika, it is shared.
Okay, sir, wait. Can you please stop your screen?
Right.
Is it
Okay.
visible, sir?
Yeah. Visible to me. So this is the last session for this meeting and day one conference. And it is the session is sponsored by Zydus, and I thank Zydus for participating in this meeting. And Dr. B.S. Ankit Nehra was little bit ill and he was unwell, so I take the privilege of presenting this. So this topic is the value of oral GnRH antagonist in androgen deprivation therapy in prostate cancer. Next, please. So this is the slide which every time we show or flash on the screen. Prostate cancer diagnosis may occur at various stages, everyone knows, and it progresses through the different pathways also. Sometimes you find the de novo metastatic prostate cancer, and almost it is 70% patient in our clinical setting. They comes with the metastatic disease and especially the bone mets, and the patient is metastatic but hormone sensitive prostate cancer. Sometimes patient comes to us in the localized or locally advanced prostate cancer. We give definitive therapy, it is surgery or maybe robotic surgery or EBRT in conjunction with the androgen deprivation therapy. Then if a patient has been treated with a definitive therapy, after some period of time, it depends on the initial disease, aggressiveness, grade of the tumor, and sometimes patient might progress biochemically because they have started increasing the PSA levels. So there is a biochemical recurrence, sometimes a radiological also. And from this juncture, patient might progress to the metastatic disease or non-metastatic disease. So these are two categories where metastatic disease is hormone sensitive or maybe non-metastatic castration resistant prostate cancer. That means we have PSA was increased, we have done the castration, maybe medical or maybe surgical, still patient is in the non-metastatic state and patient has the castration resistant prostate cancer. This entity is very scarcely found and we are searching for this category patient because we have one trial, sponsored trial, and in this setting, patient might have the biochemical recurrence but have the metastatic disease, which can be again classified under the high volume, low volume, and oligometastatic disease. Then patient will be treated according to the his general condition, performance status, disease status, and the hormone status. So ultimately, all the group of the patient will turn into the metastatic castration-resistant prostate cancer, and from this stage the survival is tough and usual median survival from this MCRPC is around 2 years or less than 2 years. So our whole effort should be that patient should not turn into the metastatic castration resistant prostate cancer. We should hold the disease either here or might be here. So the hormone sensitive prostate cancer defined as that has either not been treated with or is still responsible for the ADT. Next, please. So this is the physiological diagram where how the GnRH analogs or antagonists work on the hormone status or testosterone level. So you see the the gonadotropin releasing hormone is secreted by the hypothalamus, and then it goes to the pituitary, and then further hormone you can say the backbone setup hypothalamus, then it goes to the anterior pituitary. Pituitary will secrete FSH and LH. They go to the testes, and then testosterone is secreted, and then testosterone comes to the nucleus of the prostate cancer cells, and then they might grow. So we need to break down this axis, which is known as the GnRH axis. So we have various tools. We have the GnRH agonist and antagonist. So since ages we have the leuprolide, goserelin, triptolin, biserelin, and hysterelin. and many of them are available in India and are being clinically used. GnRH antagonist also we have used quite significantly, and Degarelix is the parenteral preparation, and now Relugolix has been launched as an oral preparation. So primary objective with ADT is to reduce circulating androgens by cutting this either feedback mechanism or directly antagonize the secretion of the GnRH. Bilateral orchidectomy was the original form of ADT and largely replaced by the medical castration. So if the patient is going for bilateral orchidectomy, this is a foolproof method, single time, one time method, and uh, nothing is in competition with this orchidectomy. But nowadays we are supporting medical castration because various hormones are available which can cut down this GnRH feedback mechanism, and the results are similar on the prostate cancer cells. So and testosterone level, and patient has a psychological factor that he has intact testes, though they might not be hormonally active. So with this, we move to the next slide. What does GnRH agonist and antagonist does? We have earlier also said agonist will increase the GnRH level, and by the negative feedback mechanism it works, and then it getting down the testosterone level of testes, and if testosterone level goes down, then prostate gland will be you can shrunken down, the tumor will be shrink. But as they are agonists, then initial surge of the testosterone will be there. So there is a well-known side effect, like there is a flare mechanism in the prostate cancer cells. And sometimes it is very important once the patient is presented with the bone mets or spinal met, and there is a impending cord compression. And if you give GnRH agonist, and there will be flare reaction, the tumor might increase in the size, and there will be further worsening of the cord compression. So this is the funda behind it. And GnRH antagonist, they directly antagonize the hormone secretion from the hypothalamus, and this antagonist inhibit the gonadotropin release by receptor blockade, and there is a luteinizing hormone and testosterone suppression, and this is the mechanism where if you want to have the active or earliest effect, then you need to apply the antagonist. Next, please. So safety announcement October 20 in 2010, the FDA notified that manufacturer of the GnRH agonist of the need to add new safety information, and that was what it was increased. There was increased risk of diabetes and certain CVDs, heart attack, sudden cardiac death, and stroke. So these are basically the problem with the older population, and that might increase or aid into this particular risk. So the notification was based on the FDA's review of several published studies. Next, please. So since very long, we know like they might increase the risk of the cardiac death. So warning and precaution on the leuprolide package insert: cardiovascular diseases, increased risk of the myocardial infarction, that is MI, sudden cardiac death, and the stroke has been reported in association with the use of GnRH analogs in the man. Monitor for the cardiovascular disease and manage according to the current clinical practice. So if patient has the significant disease, triple vessel disease, or low ejection fraction, you might not use this leuprolide. Cardiovascular disease, increased risk of developing myocardial infarction, sudden cardiac death, and stroke has been reported in association with the GnRH agonist in the men. Next, please. This was FDA warning. Now, the Degarelix, that is antagonist versus leuprolide, were compared in the study, and it was a randomized open-label phase 3 trial. Patient with adenocarcinoma of the prostate of any stage with an indication of the ADT and no prior neoadjuvant hormone therapy received patient were allowed. The odd number was 610. Patients were randomized into the two group, like Degarelix, that is antagonist arm, and leuprolide acetate. So leuprolide was given 7.5 mg monthly as a control arm, and then it was compared with the loading dose of 240 mg, then it was 80 mg per month. Key efficacy outcome were cumulative probability of testosterone less than 50 nanogram per deciliter from days 28 to 364 days, that is 1 year. Okay, median PFS at 14 and 28 days were significantly lower with the degarelix than the leuprolide, and the p value was significant. That was p value was less than 0.001. So degarelix was non-inferior to leuprolide at maintaining low testosterone level. It achieved faster and it maintained for longer period of time. That was the conclusion of that study. Next. That is again, this is a cardiovascular risk. The major adverse cardiovascular event, that is MES, MACE, occurred in 5.5% patient assigned to the degarelix and 4.1% patient assigned to the leuprolide. Next. So this is a publication in New England Journal of Medicine, which says which was published in 2020. The oral relugolix for androgen depression therapy in advanced prostate cancer. Next. So this is the popular HERO study, and the trial design was it was a randomized open label phase 3 trial. Patient with a prostate cancer who were candidate for the more than 1 year of ADT and no MAS, means no major adverse cardiac event within 6 months were randomized into two arms. The patient number was 930. It was 1:2 arm randomization. 120 mg relugolix per oral was given after a loading dose of the 660 mg per oral, and it was compared with the leuprolide acetate with the 11.25 or 22.5 mg IM in the 3 monthly arm. So the primary endpoint was the sustained testosterone suppression to the castrate level, that is less than 50 nanogram per deciliter throughout the 48 weeks. 48 weeks means almost 1 year, and secondary endpoint was non-inferiority with the respect to the primary endpoint in the castrate level of the testosterone level on day 4 and profound castrate level, that is defined as less than 20 nanogram per deciliter on the day 15. Testosterone recovery was evaluated in the subgroup of the patient, and there was one good paper or a preclinical study which has stated like if you get the profound testosterone suppression, that is castrate level that is less than 20 nanogram per deciliter, there is a long-term suppression of the disease or long-term survival benefit. Next, please. So both the arms were very well matched and balanced. Biochemical relapse patient were taken like 49.7% in the relugolix arm, and there were leuprolide was 51.3% patient in the leuprolide arm. Newly diagnosed androgen sensitive metastatic disease 22.7% in the one arm, and other arm was exactly same. And advanced localized disease was 27.7% and 26%. The median PSA level was 11.7 versus 9.4. Testosterone level median was 415 at the baseline, and here it was 395 in the leuprolide arm. So the total cardiovascular risk factor were present in the 91.6% in the relugolix arm and 94.2% in the leuprolide arm. So the risk factor were actually there were lifestyle risk factors like patient may be obese, sedentary workers, cardiovascular, cerebral vascular risk factors were present in 78% arm in the experimental arm versus 82% in the leuprolide arm, and history of the mass taken very seriously, and they were only 13.5% and 14.6% in the leuprolide arm. Though they have filtered the patient very stringently, but still there were almost 13 to 14% patient had the mass, that is major adverse cardiac events in the past. Next, please. So this is the relugolix efficacy. You can very well see relugolix had a response rate in respect to the decreasing testosterone level in the 96.7% of the patient, whereas leuprolide had the 88.8% patient. And what the primary endpoint was? Lowering the testosterone level by more than 90%. And this was the effect was significant in the terms of the stats. It was 0.0001. P-value was highly significant. Next, please. So the superiority threshold was high, and this is the relugolix efficacy. You can see this is the orange line is depicting the relugolix. as it is a direct antagonist, so there is no initial surge. This is the sign shows initial surge with the agonistic preparation, that is leuprolide. So once you start the treatment, these are the first week only that goes very down. It is around 50, around 50. So it is in the first week only they achieve the castration level. So this is very amazing thing up with the religolics. And in the first week or maybe around 2 weeks, patient have the initial surge. That is the thing with the leuprolide, and this gives sometimes the point of concern if the patient is clinically compromised, or sometimes patient might have the increase in the urinary outlet obstruction, or maybe if there is a cord compression, patient might be worse, symptomatically worsen. At the week 5, this comes in line with the religolics, but still it is religolics is better till week 17, right? So this is the thing. And how the testosterone recovery, if you stop the drug at 49 weeks, the testosterone recovers very nicely. So in the curative setting, if you want to, that patient might recover with the testosterone. In the definitive setting, then this is the best agent. Again, in the week 30 or 60, patient might be having the normal testosterone level. His sexual life and other things are very much normal. Next, please. So these are the secondary endpoints. Non-inferiority analysis of sustained castration level. Patient achieved in 96% of the patient. Here it is 88.8%. P-value is highly significant. Cumulative probability of testosterone suppression to less than 50 nanogram per deciliter on the day 1. Day 4, it was 56% patient, and here it was 0, because initially the patient had the surge. So it is again the p-value was significant. Cumulative probability of testosterone suppression at less than 50 nanogram per deciliter on the day 15, it was 98% in the religolics arm, whereas it was 12% only in the leuprolide arm. PSA response at the day 15 followed by the confirmation of the day 29, it was 79.4%, here it is 19%. And the cumulative probability of profound testosterone suppression. This is a very important point. Profound suppression was defined as less than 20 nanogram per deciliter testosterone level, and it was there in the 78.4% of patient, while only 1%. So almost no patient had attained the profound testosterone suppression level. So again, the p-value was highly significant. Mean FSH level at the end of week 24, it is around 1 point, it is almost similar. Next. So this is the cumulative incidence of the mass. If you see the leuprolide arm, it is quite significant. And the it was in the percentage of 5.6%, whereas in the religolics arm, it was 2.8%. The hazard ratio was 0.46. Next, please. There was 54% patient you could save for happening mass in the religolics arm. So this is again safety summary. Grade 3-4 effect happens in, you can see mass only 1.3%. Here it is grade 3-4, it is 1.3, it is similar, but any grade it was 6.2, whereas it is 2.9%. Patient might have diarrhea, constipation, arthralgia, and hypertension in the various levels. In the religolics arm, hot flushes are 54%, because immediately patient having the castration level. Attain the castration level, that to be the profound level. So it is most common and most worrisome problem with the religolics. Next, please. Cardiovascular assessment needed in the patient with the prostate cancer receiving ADT. More than 30% did not get any comprehensive cardiovascular assessment, but we should advise patient to go for the this cardiovascular assessment in the area of in the era of the litigations and all that. In patient receiving ADT in 2010, AHA or ACS or AUA recommended regular assessment of the cardiovascular risk factor like BP, lipid profile, blood glucose level, etc. In 2021, NCCN guideline recommends screening and intervention to prevent or treat diabetes and cardiovascular diseases. Next, please. Next slide. So impact of the concomitant cardiovascular therapies. on efficacy and safety of the relugolix versus leprolide, subgroup analysis of HERO study in advanced prostate cancer. So in this phase 3 HERO study, many patients on the other cardiovascular disease, because you see the patients are around 70 or 75 years of the age. So they must be on the previously from the antihypertensive drug, antithrombotic like aspirin or clopidogrel or some lipid modifying agent. This is a very common scenario. So almost around more than half of the patient were on the other cardiovascular drugs. Next. So what was learned from this study? Sustained castration level rates were generally consistent with the overall estimate of the oligolics and leprolide observed in the overall population. Incidence and types of the adverse event among men who received this medication were mostly consistent with overall population, and some increases the grade 3 more than grade 3 and fatal AEs. Overall relugolic suppressed testosterone and was generally well tolerated when given with the concomitant CV drugs, cardiovascular agents. Next. So observation from the US database and the first year after the launch. So they say like real world characterization of the patient receiving relugolix or androgen deprivation therapy injection in combination with oral anti-androgen in 2021. They have said, next please. Next. So this is the US database. Percentage of the patient receiving combination with the other medication and the androgen deprivation therapy or androgen receptor inhibitors distributed by the ADT agents. So you can see this is the abiraterone, aplutamide, dolutamide, and enzalutamide. It can be given with the other agents, and almost you can see in the blue is enzalutamide. So 38.2% patient received enzalutamide with the relugolix therapy. Next, please. Okay. So this is the utilization of androgen deprivation therapy among urology practices. You can very well see various utilization of the relugolix, or sometimes the patient maybe have a transition from the other therapy to relugolix. Objective was the real world utilization of the relugolix in the US during the first year of availability. It was 2021, and documented transition between the injectable and oral androgen deprivation. So patients were allowed to be opt the oral therapy rather than injectable therapy. So most relugolix utilization was observed in the patient who were new to ADT in the 2021, and patient transitioning from the relugolix from another ADT were more likely to have metastatic disease. The most frequent transition were from the leuprolide to relugolix. Next. Next, please. So conclusion of this talk: differences in the mechanism of action amongst the ADT are important and may affect both treatment and the AEs experienced by the patient. Identification and management of the AEs with ADT are critical component of the disease management. And you see the AEs include metabolic diseases, musculoskeletal, cognitive, neuropsychiatric, as well as sexual dysfunction. So it is very tailored approach which androgen deprivation therapy to be given to the patient. So if patient is metabolically compromised or a patient has a very poor muscular mass, then you might think the other therapies. Careful attention to the cardiovascular management in men receiving ADT should reduce the AEs and improve outcome, or at least we should advise them to go for the frequent cardiovascular checkup by the cardiologist. Newer options have emerged for ADT. Example is oral relugolix with a good balance of the safety and efficacy. Next. So this is the last slide. This was, and thank you very much. And I would like to thank organizers and the participants and the speakers who spoke very well on the various recent advances and the practice changing abstract and the clinical things. And I would like to thank our scientific partners, AstraZeneca, who have sponsored the session, Merck, Roche, Fresenius Kabi, Zydus, Dr. Reddy's Lab, Cipla, BDR, NATCO, Lupin Oncology, Stents, Novartis, and Vitaris. I would like to thank CRSF also, Roche, and these are the various, you can see the product available under the various pharma companies and which they have supported to the organizer. Yeah. Right. Thank you very much, Team Horizon, for supporting in the technical support and the other things. Thank you very much.
Thank you so much,
We will
Dr.